Right, so a very good evening, everyone. Welcome to the last session of the rapid revision of the internal medicine. So, in the previous sessions, we tried to revise the cardiology and endocrinology on day one, and on day two, we have revised neurology and nephrology. And yesterday, we tried to discuss the respiratory system and as well as connective tissue disorders. And all these PPTs or PDFs with annotations have been sent on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gupta. And as well, they also have been sent on Dr. Bhanu Prakash Telegram channel as well. So you can just download those PDFs, and that will be definitely useful for you for your quick revision in the last moments of your preparation. So, and yesterday, when we were discussing the respiratory system, a part of the respiratory system was left out. Now, we'll try to finish the remaining part of the respiratory system. Then we'll complete gastroenterology and as well as the infectious diseases in this particular session. Okay. So that will be the plan for today. So the session may be around 3 hours. So we'll try and sit and try to complete all the topics. Okay. Right. Now, if you take the topic, so yesterday the last topic was the bronchiectasis. So the next topic for today is the bronchogenic carcinoma. So bronchogenic carcinoma is one particular clinical condition where you can have the presence of clubbing. There are actually many respiratory conditions where there can be clubbing. What are the respiratory conditions where you will have clubbing? Interstitial lung diseases, cystic fibrosis, lung abscess, then your bronchogenic carcinoma, and even in case of necrotizing pneumonia, these are all the conditions where you will have clubbing. But in case of bronchogenic carcinoma, we have four types of bronchogenic carcinoma, out of which, in which type of bronchogenic carcinoma, the clubbing is least common, right? Any one of you? So please remember, the clubbing is least common in case of the small cell carcinoma of the lung, right? Now, let me just quickly, tell you all the important points related to the bronchogenic carcinoma. So if the question is asked, like, what is the most benign tumor of the lung? The most benign tumor of the lung, it is the hamartoma. So hamartoma, it is the most benign tumor of the lung. And overall, if you take the lung pathology, what is the most common cause of recurrent hemoptysis? Most common cause of the recurrent hemoptysis will be bronchial adenoma, right? That will be the most common cause of the recurrent hemoptysis. And what exactly among various malignancies, like what we can have in the individual, what is the most common cause of cancer death? The most common cause of the cancer death will be bronchogenic carcinoma, right? That would be the most common cause of the cancer death. And what is the most common risk factor for the development of bronchogenic carcinoma? The most common risk factor will be the smoking. Now, apart from smoking, what is the most common natural risk factor that can cause bronchogenic carcinoma is the exposure to radon gas, right? Exposure to radon gas. This is an environmental pollutant that can cause bronchogenic carcinoma. And the next important point is, in these patients with bronchogenic carcinoma, like we have four important types of bronchogenic carcinoma. That is small cell carcinoma, squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. Now, out of which you take this adenocarcinoma. Adenocarcinoma is the one which can cause the Pancoast tumor. Now, in case of Pancoast tumor, which rib is affected? It is the first rib which will undergo the erosion, right? It is the first rib which will undergo the erosion. And what are the most common nerve roots which are involved in the Pancoast tumor? The most common nerve roots which are involved in Pancoast tumor is C8, T1, and as well as T2. So these are the most common nerve roots which are involved in the Pancoast tumor. Now, among all these types of bronchogenic carcinoma, what is the most frequent histological type of bronchogenic carcinoma? Most frequent histological type of bronchogenic carcinoma will be adenocarcinoma all over the world. But particularly if the question is asked like what is the most common type of bronchogenic carcinoma in India, then the answer will be squamous cell carcinoma, right? And what is the most common histological variety which is seen in non-smokers? That will be adenocarcinoma. Whereas the remaining all types of bronchogenic carcinomas, they can occur in smokers or they occur in smokers. But the one which is seen in non-smokers will be the adenocarcinoma. And even in young patients also, the most common bronchogenic carcinoma will be the adenocarcinoma. And even the most common histological variety in females is also the adenocarcinoma. Right? So these are some of the important points on the adenocarcinoma. The next is the most common site for metastasis from carcinoma lung. That means from carcinoma lung, which particular organ will take that metastasis most commonly? That will be the liver. Now, apart from that, if the question is asked, what is the most common endocrine organ to be involved by carcinoma, endocrine organ to be involved by metastasis of the carcinoma lung, that will be the adrenal gland. Right, that will be the adrenal gland. So adrenal gland, it is the most common endocrine organ to be involved by metastasis of the carcinoma lung. Now the next question is, from carcinoma lung, which metastasis will get transmitted to the opposite lung? That means in which type of bronchogenic carcinoma, like the metastasis can be transmitted to the opposite lung? The answer will be adenocarcinoma, because adenocarcinoma is a peripheral type. In adenocarcinoma, the part of lung which is being affected is the peripheral part of the lung. So from that peripheral part of the lung, it can easily metastasize to the opposite lung. And what is the most common tumor that will metastasize to the heart? That will be bronchogenic carcinoma. So you have to understand the question here. From bronchogenic carcinoma, to which organ the metastasis most commonly goes is to the liver. But the question is like, most common tumor which will metastasize to the heart. That means to the heart, which bronchogenic carcinoma, which type of malignancy commonly metastasizes? That will be bronchogenic carcinoma. And what are the histological varieties that will cavitate? The cavitation is seen in case of large cell carcinoma and as well as the squamous cell carcinoma. Right, large cell carcinoma and squamous cell carcinoma is the one, they are the histological varieties that will cavitate. Now, what is the histological variety that is having central in distribution? The histological variety that is central in distribution will be squamous cell carcinoma. That is what is the bronchogenic carcinoma which has central in distribution. And the type of bronchogenic carcinoma which has peripheral distribution will be the adenocarcinoma. So adenocarcinoma is the one which has the peripheral distribution, right? Whereas your squamous cell carcinoma, small cell carcinoma are those which have the central distribution. Next, most common variety associated with the paraneoplastic syndrome. The one which is associated with paraneoplastic syndrome will be small cell carcinoma. Now, what do you understand by the word paraneoplastic syndrome is, this small cell carcinoma is associated with the development of syndrome of inappropriate antidiuretic hormone, and it is associated with the development of the Cushing syndrome, right? So this will be the paraneoplastic syndromes which are associated with the small cell carcinoma. And one more important question is, which is the type of bronchogenic carcinoma most commonly associated with hypokalemia? Right, the type of bronchogenic carcinoma associated with hypokalemia will be small cell carcinoma. Now, why is that? Right, why is that? Why? Because this small cell carcinoma will be a source for the ectopic ACTH secretion causing Cushing syndrome. And this ectopic ACTH causing Cushing syndrome, whenever the steroids are produced in excess quantity in Cushing syndrome, that steroids will go and activate the ENaC channels, that is epithelial sodium channels within the distal convoluted tubule. And once the epithelial sodium channels are activated, there will be sodium and water retention and then potassium excretion. And that is the reason why there will be hypokalemia in case of small cell carcinoma. And most common histological variety that is associated with hypercalcemia will be squamous cell carcinoma. Now, why is that? Because squamous cell carcinoma is a source for the release of parathormone related protein, and this parathormone related protein is the one which will increase or stimulate the parathormone production, and that will cause bone resorption resulting in hypercalcemia. And histological variety most responsive to chemotherapy and as well as the radiotherapy will be small cell carcinoma, right? Because small cell carcinoma is the most aggressive tumor, right? It's the most aggressive tumor. There is very high chance of metastasis to the distant organs. Which one? Small cell carcinoma, which is also called oat cell carcinoma. And this small cell carcinoma, because it has the higher tendency of metastasis, surgery will be of no use in case of small cell carcinoma. You have to give only chemotherapy in case of small cell carcinoma. Whereas the histological variety with best prognosis, that will be squamous cell carcinoma, right? This squamous cell carcinoma and as well as adenocarcinoma, like most of it, they are like localized tumors. So we can do surgical treatment in case of squamous cell carcinoma and as well as adenocarcinoma. But in case of small cell carcinoma, surgery won't suffice because there is high chance of metastasis. So that is the reason why chemotherapy would be the best for small cell carcinoma. So these are some of the important points related to bronchogenic carcinoma. And you also need to know, right, what are the tumor markers for bronchogenic carcinoma? That includes carcinoembryonic antigen. Now, what does this carcinoembryonic antigen presence tells you? The carcinoembryonic antigen presence tells you that the bronchogenic carcinoma is having metastasis, right? So it is a marker of, right? It is a marker of metastasis. Okay, which one? Carcinoembryonic antigen. And one more important marker is neuron specific enolase. This neuron specific enolase, if it is being present, it is the prognostic marker, right? This is a prognostic marker in small cell carcinoma of the lung. Okay, so these are the two important tumor markers that are being asked previously, right? So having said about the bronchogenic carcinoma, now we move on to the next important topic, that is pulmonary thromboembolism. So in pulmonary thromboembolism, the clinical manifestations completely depends upon the size of the embolus. Now if suppose if there is presence of massive pulmonary embolism, the patient will have the dyspnea, right? The patient will have the dyspnea. So dyspnea will be the most common symptom in patients with the pulmonary thromboembolism, right? And that too, the dyspnea will be a sudden onset dyspnea, right? Next, the other important point is in case of massive pulmonary embolism, there will be increased afterload on the right ventricle. So thereby, the interventricular septum from the right ventricle, it is being pushed into the left ventricle. Usually the interventricular septum is present in between the right ventricle and left ventricle. But here, because of increased afterload on the right ventricle, the interventricular septum is being pushed onto the left ventricle. So the LV lumen reduces. Once the LV lumen size reduces, the cardiac output decreases, and thereby there will be decrease in cerebral perfusion, resulting in the syncopal attack. And why is this particular syncopal attack? That is because of the hypotension. That is because of the hypotension. And another important manifestation is the cyanosis, that is because of decreased oxygenation. So these are the symptoms suggestive of massive pulmonary embolism. Now what are the symptoms which are suggestive of the small emboli? See, this small emboli, they enter into the bronchial circulation, causing the pulmonary infarction. And because of the pulmonary infarction, the individual can develop the pleuritic type of chest pain, right? The patient develops the pleuritic type of chest pain, that is because of pulmonary infarction. And the other features of the small emboli is there can be cough, and there can be hemoptysis which can be seen, and the other manifestations are palpitations can also be there in patients with a small emboli. Now what is very important here in case of pulmonary embolism is the diagnosis. So now in case of pulmonary thromboembolism, what is the investigation of choice? The investigation of choice will be the CT pulmonary angiography. That is the investigation of choice. But in certain scenarios where we cannot use contrast, we cannot do CTPA. That is CT pulmonary angiogram you cannot do in a scenarios where, like for example, a pregnant female presented with pulmonary embolism. Can you do a can you do a CT pulmonary angiogram? No, because there is high risk of radiation to the fetus. So in such case, what is the second best investigation will be ventilation perfusion scan. So that would be the second best investigation for the diagnosis of pulmonary embolism. Now ECG manifestations are very important in pulmonary embolism, which have been asked very frequently in the last exams. In acute pulmonary embolism, what do you think is the most frequent ECG finding? S1Q3T3 pattern, P pulmonale, sinus tachycardia, right axis deviation. So once you get this particular type of question, many of you are having the highest tendency to go with S1Q3T3 pattern. Let me tell you, that is not the most common or most frequent ECG finding in pulmonary embolism. The most frequent ECG finding in pulmonary embolism is the sinus tachycardia. This S1Q3T3 pattern, it is present only in 7 to 10% of patients with the pulmonary embolism. Now, what are the other features of pulmonary embolism next to the sinus tachycardia? Definitely one point is sinus tachycardia. The other ECG finding of pulmonary embolism is that in these patients with pulmonary embolism, like what happens is there is increased afterload on the right ventricle. So you will have the features of the right heart strain pattern, right? You will have the features of the right heart strain pattern. Now, what are those features of the right heart strain pattern, right? Number one, that is right axis deviation. Next is the development of the right ventricular hypertrophy. It may not be an acute event. In case of chronic pulmonary embolism, there can be development of right ventricular hypertrophy. But what are the other features of the right heart strain pattern apart from right axis deviation? The other features will be the development of RBBB, that is right bundle branch block pattern can be there, and there will be inverted T waves in V1 to V3, right? Inverted T waves in V1 to V3, okay? And there will be also ST segment depression in V1 to V3, okay? So these are the features of, or these are the ECG changes that is being present within the pulmonary embolism, right? Next, then yes, this is what is your S1Q3T3 pattern. This S1Q3T3 pattern is present only in 7 to 10% of patients, right? That is, you have the presence of deep S wave in lead V1, lead 1, I'm sorry, deep S wave in lead 1, then you have the deep Q wave in lead 3, and then inverted T wave in lead 3. So this is what is called as the S1Q3 T3 pattern. Now the next important investigations in pulmonary embolism which have been asked previously is the chest X-ray. In which clinical condition do you see this particular sign? That is nothing but your Hampton's hump. What is Hampton's hump? The presence of the wedge-shaped infarct. And you come across this Hampton's hump in case of pulmonary embolism. But the sensitivity of these X-ray findings are very less. The sensitivity of this Hampton's hump is only 21%. So they are not 100% sensitive. But if this particular X-ray is being given with wedge-shaped infarct, that is suggestive of the pulmonary embolism. Next, the next important you can see here, what are the chest X-ray findings and in which clinical condition you can have here. So you can observe here that there is enlarged or dilated, dilated right descending pulmonary artery. There is enlarged right descending pulmonary artery. Now the presence of dilated or enlarged right descending pulmonary artery, like what exactly is this sign? This sign is called as the Pallas sign. Okay, and why is that there will be dilatation of right descending pulmonary artery? That is because of the pulmonary hypertension. Next is, what are the chest X-ray findings and what is the diagnosis in this scenario? So if you take this chest X-ray, so in this chest X-ray, you can see, right, that there is this is nothing but your Western mark sign. Right, Western mark sign. Okay, so right where there is, okay, so these are the three important signs. One is the Hampton's hump where you have wedge-shaped infarct, enlargement of right descending pulmonary artery, that is Pallas sign, and next is the Western mark sign. Okay, right. Now after having discussed about the chest X-ray, the next important is about the Ddimer. So Ddimer is definitely elevated in patients with pulmonary embolism, but not only in pulmonary embolism, there are many other conditions where the Ddimer can be elevated. But the question is, D-dimer values may be elevated in all of the following conditions except, this is one of the PYQ, right? Myocardial infarction, pneumonia, anticoagulant therapy, and pregnancy. So please remember, in case of the anticoagulant therapy, D-dimer value is not elevated because when the patient is on anticoagulant therapy, there is no thrombus formation. And what exactly is your D-dimer? D-dimer, it is a fibrin degradation product, right? D-dimer, it is a fibrin degradation product. That is what is your D-dimer. Okay, now this fibrin degradation product comes from the thrombus. When the patient is on anticoagulant, where is the question of thrombus formation? No thrombus formation. When there is no thrombus, there is no fibrin degradation product. So D-dimer value may be increased in all of the following conditions except, that is anticoagulation therapy. Investigation of choice, just now we have discussed, that is CT pulmonary angiogram. That is the investigation of choice. Now, how do you treat these patients with the pulmonary embolism? So this is one clinical scenario which has been asked previously. A young patient presents to the emergency with acute pulmonary embolism. Patient's blood pressure is normal, but ECG reveals right ventricular hypokinesia and compromised cardiac output. The treatment in this patient will be thrombolytic therapy, then anticoagulation with low molecular weight heparin, anticoagulation with warfarin, inferior vena cava filter. So how is that you will manage this patient? So remember, the treatment in case of pulmonary embolism, it all depends upon the severity of pulmonary embolism. Like what is that? Like for example, you see this table. If the individual with pulmonary embolism is having normal blood pressure and normal right ventricle, right? In that case, just give anticoagulants, right? Anticoagulants, that's all. But if there is recurrent pulmonary embolism, then you put the patient on IVC filter. That is one scenario. And you take the second scenario. The patient with pulmonary embolism is having hypotension. Then in that particular patient, you need to do anticoagulation plus thrombolysis. Or if required, embolectomy should be done. That is, if a patient with pulmonary embolism having hypotension. And what is the reason for hypotension we have discussed. But our patient, which the clinical scenario which I have given to you, it comes under this third one. That is, the patient's blood pressure is normal, but there is RV hypokinesia. So you can see here, what is there in this patient? The blood pressure of this individual is normal, but there is RV hypokinesia. Now, in this scenario, what is that you have to do is that you need to individualize the risk assessment. For suppose, if the individual is a young patient where there is no bleeding risk, in this patient you can do thrombolytic therapy. The patient is a young patient. But in the same scenario, if it is there in elderly individuals where there is increased risk of bleeding, so in this patient where the patient is having like comorbidities and high risk of bleeding, in these patients we just give only the anticoagulants, we don't give the thrombolytic therapy. Okay, so this is how you need to manage a patient with the pulmonary embolism. Now next important thing in case of pulmonary embolism is about the criteria. The name of the criteria is the modified Wells criteria for diagnosis of pulmonary embolism. And what has been asked in one of the exam is, which among the following is not the variable, or which of the following is not the parameter in modified Wells criteria. So you have to know what are the variables which have been taken. Signs and symptoms of DVT present or absent. Alternative diagnosis less likely than pulmonary embolism. That means there should not be any other predisposing condition for causing shortness of breath in this individual. Heart rate more than 100 is there or not? Immobilization for more than 3 days, is it there or not? Prior pulmonary embolism history or DVT history is there or not? And is there hemoptysis and as well as the malignancy? So what has been included in the MCQ was the cyanosis, right? Which among the following clinical variable is not the part of modified Wells criteria? Cyanosis is not the part of the modified Wells criteria. But does cyanosis develop in pulmonary embolism? Yes, it can develop, but it is not the variable of the modified Wells criteria. Now, once the scoring system is being taken, like for suppose, if the individual is having a score of more than 6 in modified Wells criteria, so you have to assume that there is high probability of, right, there is high probability of pulmonary embolism in this patient. And if the score is like 2 to 6, then the patient is having moderate probability of development of the pulmonary embolism. And if the score is less than 2, then the patient is having low probability of development of pulmonary embolism. So this is what is your modified Wells criteria, which is useful in diagnosis of the pulmonary embolism. So with this, we are done with the topic of the pulmonary embolism, where the patient will present with the sudden onset dyspnea, right? And yes, the next important topic for the discussion will be the pleural disorders. And in this pleural disorders, let me take up the discussion of the pleural effusion. Okay, so like you need to know how much is the normal quantity of the pleural fluid. Normal quantity of the pleural fluid is around 5 to 15 ml. And if the quantity of the fluid which is accumulated in the pleural space, that is in between parietal pleura and visceral pleura, if it is like more than 20 to 30 ml, we call it as the pleural effusion. Now this pleural effusion, depending upon the content, right, depending upon the constituents within the pleural fluid, we classify that into two types, that is the transudative type of pleural effusion and as well as the exudative type of pleural effusion. So what is the basic difference between these two? See, the protein content in case of transudate, it is around 3 grams per deciliter, whereas in exudate it is more than 3 grams per deciliter, right? In exudate it is more than 3 grams per deciliter. And fluid protein to the serum protein ratio in transudate it is less than 0.5, whereas in exudate it is more than 0.5. Whereas you take fluid LDH to the serum LDH ratio less than 0.6 in transudate and it is more than 0.6 in case of the exudate. So these three variables are taken into consideration of a criteria called as the Lights criteria. So Lights criteria, if it is positive, that is very much suggestive of exudative type of pleural effusion. Now what exactly should be there in the Lights criteria? These three variables should be there. So if any one parameter is there out of these three, suggestive of exudative type of pleural effusion. Okay, right. So this is about like how you will diagnose whether it is a transudate or the exudate. And the next important question you need to know is like, what is the most common cause of pleural effusion? Most common cause of pleural effusion will be the congestive heart failure, and most common cause of transudate also will be the congestive heart failure, and most common cause of exudate will be the pneumonia, right, or the infectious pathology. So next to this pneumonia, you can also answer the tuberculosis. So the tuberculosis and as well as the pneumonia, these are the most common causes for the exudative type of the pleural effusion. All right. Now, having said about this, now how will you diagnose this pleural effusion? See, the diagnosis, the clinical manifestation of pleural effusion is that they can have gradual onset dyspnea, right? They'll not have sudden onset dyspnea. It's a gradual onset dyspnea, right? And on examination, you will have the percussion note as a stony dull note, and the trachea is deviated to the opposite side. Vocal phlebitis and vocal resonance is being reduced, and on auscultation, the breath sounds will be reduced. On auscultation, the breath sounds will be reduced. That is what you will see in the pleural effusion, right? Now, next important is the chest X-ray in case of the pleural effusion. chest X-ray in case of pleural effusion, what is the earliest manifestation of the pleural effusion on the chest X-ray? So there will be blunting of the postophrenic angle, right? There will be blunting of the postophrenic angle. That is the earliest manifestation in the pleural effusion, blunting of the postophrenic angle. And the other changes will be, there will be shift of the mediastinum to the opposite side, that is trachea is being shifted to the opposite side, and there will be presence of the homogeneous opacity, right? The presence of the homogeneous opacity. And the next important point is the curve, right? What is this curve? This particular curve, it is called as Ellis S-shaped curve, right? This curve, it is called as the Ellis S-shaped curve. That is what you will see in case of the pleural effusion. Now, what exactly is this X-ray suggestive of? That is the presence of the horizontal fluid level. See, the presence of the horizontal fluid level, it is seen in condition that is the hydropneumothorax, right? It is seen in condition that is the hydropneumothorax. Okay, so what exactly is your hydropneumothorax? That is the presence of the fluid and as well as the air. That is called as the hydropneumothorax, where you will have the presence of the horizontal fluid level on the chest X-ray. And the auscultation is very important in hydropneumothorax, where you have the presence of the characteristic auscultatory finding that is called as the succussion splash, right? That is called as succussion splash. That is characteristically seen in patients with the hydropneumothorax. Now in case of pleural effusion, when you have to do the pluricentesis, right? What is the point you have to do pluricentesis? One is your clinical. For example, if the patient is having dyspnea, right, because of massive pleural effusion, that is a clinical indication for doing pluricentesis. And but what is the radiological indication? You see this question. This is one of the PYQ. Therapeutic thoracocentesis should be performed if the free fluid in the lung separates the chest wall by greater than 5 mm, 10 mm, 15 mm, and then 20 mm. So this is the chest X-ray indication when you have to do therapeutic thoracocentesis. Remember, the answer is the 10 mm. So if the free fluid which is separating the lung and chest wall, if it is more than 10 mm, that is the point when you have to do therapeutic thoracocentesis, right? Next, now I will show you one more clinical scenario. A car accident patient, that means an individual had an RTA, complaints of breathlessness, dyspnea. On examination, the blood pressure of the individual is 110 by 70 millimeters of mercury, and GCS is 15 by 15, which is a good GCS. On examination, the trachea shows deviation in the suprasternal notch. So the trachea is being deviated in the suprasternal notch with reduced breath sounds in the left infraaxillary area and left inframammary area. But how are the heart sounds? The S1 and S2 is normal in intensity, and even splitting of your S2 is also normal. Chest X-ray is shown below. What is the best step in the management of this patient? Needle aspiration, pericardiocentesis, chest tube insertion, immediate thoracotomy. Now, what exactly is the scenario of the patient? An individual who had a road traffic accident. So, what this patient would have been developed? This patient would have developed the hemothorax, right? This patient would have developed hemothorax. So, in a clinical scenario of hemothorax, that is needle aspiration will not be sufficient because it's a blood which is very thick in consistency. So with the help of needle, you cannot take out the blood which is present in the pleural space. So in order to take out this particular fluid, what you have to do is the chest tube insertion, right? The correct answer here will be the chest tube insertion. So these are some of the very important points related to the pleural effusion. And where exactly you need to insert the needle when you are doing the pluricentesis is that, see, if you are inserting the needle in the mid-axillary line, you have to insert the needle in the sixth intercostal space, the mid-axillary line, and the position of the patient should be bent forward with arm extended over the couch. And where exactly you have to insert the needle within the intercostal space? You have to insert the needle. Yes, any one of you, please tell me where exactly you will insert the needle in the intercostal space. Right, you have to insert the needle over the upper border of the lower rib. Now why exactly is that? Because in the other areas you have the presence of neurovascular bundle. So that is the reason why the preferable area will be over the upper border of the lower rib. That is a preferable area where you need to do the pluricentesis by inserting the needle in the sixth intercostal space in the mid-axillary line. So this is about the pluricentesis and as well as the pleural effusion. And next important respiratory emergency is about the pneumothorax. Now, what exactly is the hallmark of the pneumothorax? The hallmark of the pneumothorax is the collapsed lung, right? That is the hallmark of the pneumothorax. That is the development of the collapsed lung. You understand? Now, whenever there is a collapsed lung, what will be the presentation of the patient? The individual will have sudden onset dyspnea, right? The individual will have sudden onset dyspnea. And among the various types of pneumothorax, the important form of pneumothorax is the tension pneumothorax, which is important respiratory emergency. And in which particular settings you get the development of tension pneumothorax? You come across this in the setting of penetrating trauma. You come across this in the setting of lung infection. You come across this when the individual is had undergone cardiopulmonary resuscitation, or there is high positive pressure mechanical ventilation. So in this particular setting, there is high chance of development of the tension pneumothorax. And these patients with the tension pneumothorax, you have to understand that the immediate management is that these patients, they require, right, whiteboard needle insertion, right? You need to do immediate whiteboard needle insertion. And where exactly you do this whiteboard needle insertion is that you have to insert the needle in the upper intercostal spaces, that is usually in the second intercostal space in the mid-clavicular line, right? So there is a controversy on this particular point where you have to do whiteboard needle insertion, right? You take the CMDT or you CMDT 2022, or you take the Harrison 21st edition, like they give very clearly that needle should be inserted in the second intercostal space mid-clavicular line for tension pneumothorax as a first line treatment. And after this, the next step will be the chest tube drainage, right? The next step will be the chest tube drainage. Okay, so this is what is your tension pneumothorax. This is definitely an important medical emergency, and if you don't treat these patients, they will develop significant hypotension and there can be cardiovascular collapse and death of the individual. Okay, right. And the next important is the catamenial lung disorders. What exactly is your catamenial lung disorders? It is the one which you come across in pulmonary endometriosis, right? Pulmonary endometriosis. Now, what do you understand by this word pulmonary endometriosis? That is the presence of the endometrial tissue outside the uterus, that is either in the lung parenchyma or within the pleura. Now, these patients with catamenial lung disorders, with every menstrual cycle, right, with every menstrual cycle, there is chance of development of the pneumothorax. That is what is called as the catamenial lung disorders, right? And what will be the important X-ray finding? The important X-ray finding is that you will observe that there is collapse of the lung, right? You will observe that there is collapse of the lung. And the other point is the presence of the hyperlucent lung field. Next is the trachea. The trachea is being, or the mediastinum or trachea is being shifted to the opposite side. So these are the features, chest X-ray features in patients with the pneumothorax. And one more important sign that you need to remember is, which has been asked as in the previous years, about the deep sulcus sign. Now, what exactly is the deep sulcus sign? Deep sulcus sign, it is the insinuation of the air into the costophrenic angle when you take the chest X-ray in the supine position. So you get this deep sulcus sign in a patient with pneumothorax when you have taken a chest X-ray in the patient in the supine position, right? Supine position. That is what is called as the deep sulcus sign, right? Next is, yes, which of the following statement about pneumothorax is a true statement? Breath sounds are increased, percussion note is decreased, always needs chest tube insertion, often needs chest tube insertion. So this is a very important point. So what will happen to the breath sounds? The breath sounds will be completely absent. Why? Because there is a collapsed lung. So breath sounds are completely absent. Okay, only in case of tension pneumothorax you get what is called amphoric breath sounds. Amphoric breath sounds are those which are having metallic quality sounds. Okay, and you take this percussion note. What will happen to the percussion note? That will be increased. There will be hyper resonant note. There are two differential diagnoses where you can have hyperresonant note. One is your pneumothorax and the other condition is the emphysema. So these are the two conditions where you will have the hyperresonant note. Now the point is, always needs chest tube insertion is a wrong statement. See, if the volume of the pneumothorax or if the severity of the pneumothorax is very less, right, if the volume or the severity of the pneumothorax is very small, then in such case we don't require to put or to place a chest tube insertion, right? So we place a chest tube insertion when there is significant pneumothorax causing collapse of the lung with sudden onset dyspnea. You understand? And when there is like very small amount of pneumothorax, there is no collapse of the lung, only just oxygen inhalation will suffice and will cause resolution of that pneumothorax. So often needs chest tube insertion is correct statement, but always needs chest tube insertion, it is the wrong statement. Okay, so these are some of the important points related to the pneumothorax. Now, after having discussed about the pneumothorax, the next important point of discussion is the respiratory failure. Now, if you take this respiratory failure, there are totally 4 types of respiratory failure. What are these 4 types of respiratory failure? That is nothing but your type 1, 2, 3, 4, right? Type 1, 2, 3, 4. Now, all of the following types of respiratory failure are correctly matched except the options are type 1 hypoxemic, type 2 hypercapnic, type 3 atelectatic, type 4 perioperative, right? So, which of the following is incorrectly paired? Which of the following is incorrectly paired, right? I can see some of the students asking the questions in the chat box, right? So you can just ask your doubts on my Telegram channel directly immediately after the session, right? So explaining the doubts, definitely it will be a break for many other students who are attending the session. So you can just type your doubts in my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Guba. Definitely I'll answer your doubts. Okay, so let us have the fluency and as well as continuity of this session without having intermittent break of clearing the doubts. Okay, right. So all of the following are types are correctly matched except. So what is the one which is incorrectly matched? That is your type 4 respiratory failure. So type 4 respiratory failure, it is the one which occurs secondary to cardiogenic shock, right? Which occurs secondary to cardiogenic shock. Whereas you take type 1 respiratory failure. Type 1 respiratory failure, it is acute hypoxemic respiratory failure. It's an acute hypoxemic respiratory failure, and this occurs due to the fluid overload, right? This occurs due to the fluid overload. Okay, now what could be the fluid overload condition? Either you take in case of pulmonary edema, either cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. Next, early stages of bronchial asthma, right? Early stages of bronchial asthma, that is mild or moderate forms of bronchial asthma. Then even in patients with the chronic bronchitis, you will have type 1 respiratory failure. And what are the features in type 1 respiratory failure? You will have hypoxia, definitely. And what about the carbon dioxide? Carbon dioxide levels, they may be normal or the carbon dioxide levels may be reduced. That is what you will observe in case of type 1 respiratory failure. The other point is the AA gradient. So if you take arteriolar alveolar gradient of oxygen, so AA gradient will be increased. That is what you will see in patients with type 1 respiratory failure. And etiology, just now we have discussed non-cardiogenic pulmonary edema, that is ARDS, or your cardiogenic pulmonary edema, mild to moderate bronchial asthma. Then your emphysema, not chronic bronchitis, I'm very sorry, emphysema. Emphysema will cause your type 1 respiratory failure. Now you take your type 2 respiratory failure. So if you take your type 2 respiratory failure, type 2 respiratory failure is due to failure of the gaseous exchange, right? There is failure of the exchange of gases, right? Or it could be because of the hypoventilation, because of the hypoventilation, because of the problem within the respiratory centers. Now what will be the parameters in the type 2 respiratory failure? So there will be hypoxia and then the hypercapnia, right? Hypoxia and as well as the hypercapnia. So these will be the points in type 2 respiratory failure. And in case of type 2 respiratory failure, what are all the etiologies that we can consider? The etiologies we can consider is there are certain conditions which can suppress the respiratory centers, like opioid intake can cause the suppression of the respiratory center. And second important endocrine disorder is hypothyroidism, that can also cause the suppression of the respiratory center. So suppression of the respiratory centers can cause type 2 respiratory failure. That is one thing. Second thing is the neuromuscular junction disorders, right? So what are those neuromuscular junction disorders like myasthenia gravis or the other conditions like Guillain-Barré syndrome and as well as motor neuron disease, where there can be paralysis of the respiratory muscles. Myasthenia gravis, Guillain-Barré syndrome, motor neuron disease, there is paralysis of the respiratory muscles causing your type 2 respiratory failure, where there is hypoxia and as well as hypercapnia. And the third condition is the myopathy, right, where there is pathology within the respiratory muscles itself, like in case of muscular dystrophies or in electrolyte abnormalities like hypokalemia. there can be development of type 2 respiratory failure. So you take any form of respiratory failure, the treatment is same. You need to treat the underlying cause, you need to supplement the oxygen with oxygen mask, and with the help of oxygen mask, if the saturation is not being maintained adequately, then you have to put the patient on non-invasive positive pressure ventilation. And even non-invasive positive pressure ventilation, if it doesn't suffice, then you have to put the patient on mechanical ventilator with endotracheal tube, right? So that is the common treatment in all the types of respiratory failure. But the only thing is, like, you need to treat the underlying cause. And what exactly is the etiology of respiratory failure is different from one to one. Okay, then you take your type 3 respiratory failure. Type 3 respiratory failure, that is the post-operative respiratory failure, where there is lung atelectasis. That means even after the surgery, the individual is unable to recover back from the effect of general anesthesia. The individual is unable to recover back from the effect of the skeletal muscle relaxant. So the skeletal muscles, like respiratory muscles, they are completely paralyzed. So once these respiratory muscles or skeletal muscles are completely paralyzed, what will happen is the lung, there will be collapse of the lung. There will be atelectasis of the lung. Okay, right. Then next is the your type 4. So type 4 is due to what? That is due to the cardiogenic shock. That is due to cardiogenic shock. See, in case of your type 4 respiratory failure, what happens is, whenever there is cardiogenic shock, there will be decrease in the respiratory muscle perfusion. Right? There will be decrease in the respiratory muscle perfusion. Now, see, respiratory muscles, like your diaphragm, external intercostal muscles and internal intercostal muscles, and you know how much of the cardiac output they take? See, they take less than 5% of the cardiac output. Which one? The respiratory muscles. They take less than 5% of the cardiac output. But when there is cardiogenic shock, because of hypotension, the respiratory muscle perfusion will be reduced, and thereby, you know, the individual will land up in the respiratory failure. Okay, so in your type 3 and type 4 also, the oxygen and carbon dioxide parameters will be similar to that of type 2. That is, they will have hypoxia and as well as the hypercapnia. Right? So these are the types of the respiratory failure: type 1, type 2, type 3. So type 1, it is acute hypoxemic respiratory failure. Type 2, hypercapnic respiratory failure. Type 3, perioperative or atelectatic lung. Type 4, it is due to hypoperfusion of respiratory muscles due to cardiogenic shock. Right? So we are done with the topic related to the respiratory failure. Right? Now you see this question. In ICU setting, patients suffering from which of the following respiratory pathology is most predisposed for carbon dioxide narcosis? Carbon dioxide narcosis means what? It should be type 2 respiratory failure. The options are motor neuron disease, asthma, emphysema, and then bronchiectasis. So motor neuron disease is the one which is associated with the development of type 2 respiratory failure. Whereas you take the remaining three conditions, asthma, emphysema, bronchiectasis, they caused type 1 respiratory failure, where the carbon dioxide levels may be normal or may be decreased because of carbon dioxide washout. Okay. Whereas only in which form of asthma you can have carbon dioxide narcosis? That is in acute severe asthma. That is in case of status asthmaticus. In case of status asthmaticus, you know, there can be hypercapnia, but not in case of mild to moderate form of asthma. Right? Now, so that was about your topic related to the respiratory failure. Next, yes. Now we will take up the next important condition. So what exactly is the chest X-ray finding? What is your diagnosis? So what is that you are seeing? You are observing, or it is very clear that one lobe of the lung, right? One lobe of the lung, you are having the presence of opacity. And this particular patient present with a high grade fever. So this is suggestive of lobar pneumonia. Right? This is suggestive of lobar pneumonia. So in case of lobar pneumonia, right, you will have the entire lobe of the lung which is being consolidated. Right? The entire lobe of the lung is being consolidated. Okay. And the next important is, you should know what is the most common organism that will be causing lobar pneumonia. The answer will be the strep pneumonia. Right? The answer will be the strep pneumonia that will be causing the lobar pneumonia. Right? And in these patients with lobar pneumonia, if you see the examination findings, right, the trachea will be central. There will be no shift of the trachea in case of your lobar pneumonia, but the vocal resonance and as well as the vocal fremitus, that will be increased in case of the lobar pneumonia, right, because it's a consolidated lung. And what will be the percussion note? The percussion note will be the presence of the woody dull note, right? The percussion note will be the presence of the woody dull note. Okay, that will be the percussion note. And auscultation is very, very important in case of the lobar pneumonia or consolidation. So the auscultation will be the presence of bronchial breath sounds, right? The presence of bronchial breath sounds. So if you see this bronchial breath sounds, what type of bronchial breath sounds you will have in consolidation? That is tubular type of bronchial breath sounds, where the individual will have hollow aspirating quality. The individual will have hollow aspirating quality. That is what is the type of breath sounds you will have in case of the consolidated lung. Now you have other types of bronchial breath sounds like cavernous type of breath sounds. Cavernous type of bronchial breath sounds you come across when the individual is having the presence of cavity within the lung, right? And next is the amphoric breath sounds. Amphoric breath sound, just now we have discussed, that is seen in case of tension pneumothorax, where the individual will have, you know, metallic quality. Okay, so that is about your respiratory sounds. Now yes, you take the another form of pneumonia. See, what are the chest x-ray finding and what is the diagnosis? See here, what is that you are finding is, you are finding that there is presence of opacities, and these opacities are like patchy. They are not like confined to one lobe, and this is what you see in case of bronchopneumonia. So in bronchopneumonia you will observe the patchy opacities, and you will notice that the bronchus is also being affected. In lobar pneumonia the bronchi is not involved, but whereas in bronchopneumonia even the bronchi is also being affected, right? And the chest x-ray will show you the presence of the patchy opacities, and the organism that can cause your bronchopneumonia will be staph. Whereas your lobar pneumonia, you have strep and you have Klebsiella, which will be causing lobar pneumonia. And next is, what are the chest x-ray finding and what is the diagnosis in this scenario? See, if you take the chest x-ray here, what is that pattern we call it as? We call this as the interstitial pattern, right? We call this as the interstitial pattern, right? So this we call it where there is lacy pattern all over the lung. And these interstitial pneumonia, what are the organisms? It is mainly the viral infections. Apart from that, you also have some bacteria, that is MLC. What is MLC? It is not member of legislative council. M is your mycoplasma, L is your legionella, C is your chlamydia. So these are the bacterial organisms which can cause the interstitial pneumonia. And not only that, even your viral infections, right? Adenovirus, influenza, your COVID-19, they will be causing your interstitial pneumonia. And these patients with interstitial pneumonia, they don't have the cough with expectoration. These patients, they'll have the dry cough. And some important points you need to know is about the legionella. See, legionella, not only pulmonary manifestations, these individuals will also have extra pulmonary manifestations, and that will be in the form of diarrhea, and that will cause the development of hyponatremia. And because of hyponatremia, the patient can have the altered sensorium and as well as the seizures. Okay, now whereas you take chlamydia, this is very common. This we have a species called chlamydia psittacosis. This is very common in those individuals who are like bird handlers. So in case of bird handlers, the organism is mainly the chlamydia psittacosis or chlamydia psittaci, and the pneumonia we call it as the psittacosis, right? The pneumonia we call it as psittacosis. Okay, next, then the another pneumonia that you need to remember is, yes, you see this, what are the chest x-ray findings and what is the diagnosis? See, this classical appearance of the x-ray, whatever is there, we call it as the ground glass opacity. Now where is that, which organism will cause the ground glass opacity? That will be pneumocystis jirovecii pneumonia, which is very common in immunocompromised patients, right? Very common in immunocompromised patients. And what will be the investigation of choice in these patients? And okay, what are the clinical manifestations? These patients with PCP pneumonia or pneumocystis jirovecii pneumonia, they'll have dry cough and exertional dyspnea will be there. Dry cough, exertional dyspnea, and ABG will show you the presence of the hypoxemia. But what is the investigation of choice is the bronchoalveolar lavage and examination, right? You need to do bronchoscopy and you have to take the bronchoalveolar lavage and you have to do the examination of the organism. Okay, and the stain what we use is methylamine silver stain in order to pick up that organism. Okay, right. And what is the drug of choice for PCP pneumonia? Drug of choice will be trimethoprim, sulfamethoxazole. This will be the drug of choice, right? Trimethoprim and sulfamethoxazole. Okay, so these are the important forms of pneumonia that you need to know: lobar pneumonia, then bronchopneumonia, interstitial pneumonia, and as well as the pneumonia caused by your PCP, where you have the presence of ground glass opacities on the chest X-ray. Next, then you see the next important topic, that is the tuberculosis. So if you see the tuberculosis, what are the various methods of transmission of tuberculosis? One is by droplet, right? Droplet transmission. Second, ingestion. Third, vertical transmission. Fourth, direct contact, right? Fourth, direct contact. Now you take this droplet transmission. See, tuberculosis transmission via droplets affects the lungs and as well as the tonsils, right? Lungs and as well as the tonsils. Now, seeding of this tuberculous organism in the tonsils will lead to what is called as cervical lymphadenopathy, right? And this cervical lymphadenopathy, this will be the most common form of the extrapulmonary tuberculosis, right? And what is the best method by which you can diagnose this tuberculous lymphadenitis? That is by FNAC. FNAC will show you the presence of the caseating granuloma. So if the question is asked like what is the most common site for extrapulmonary tuberculosis, the answer should be cervical lymphadenopathy. And next to cervical lymphadenopathy, there can be involvement of pleura and there can be even genitourinary tuberculosis. And the other methods of transmission of your tuberculous organism is by ingestion, where the individual will develop ileocecal tuberculosis, right? Where the individual will develop ileocecal tuberculosis. And why? That is swallowing of Mycobacterium tuberculosis, that can lead to the ileocecal tuberculosis. Okay, vertical transmission, that is from mother to fetus, that is what is your transplacental spread or vertical transmission. So here in vertical transmission, where is that Gons focus formed in the fetus? The Gons focus in the fetus, it is formed in the liver, right? Gons focus, it is formed in the liver of the baby during the intrauterine life. And the direct contact, see, the direct contact tuberculosis, that is through skin contact, and so this we call it as the lupus vulgaris, which is nothing but your skin tuberculosis, right? Which is nothing but skin tuberculosis. Now, once the organism has entered into the lung, what will be the most common site of Gons focus in primary and in secondary? The most common site of Gons focus in primary tuberculosis, that will be, right, that will be lower border of the upper lobe, right? That will be the lower border of the upper lobe. Whereas you take in case of the secondary tuberculosis, in secondary tuberculosis, the Gons focus is most commonly seen at the apex of the lung, right? Commonly seen at the apex of primary tuberculosis is means the individual is exposed to the organism for the first time. Secondary tuberculosis means where the organism which was already there, which has been activated. That is what is your secondary tuberculosis. Now, very important questions in tuberculosis that will be asked is the names of these lesions. So this organism will not just stay within the lung. It spreads to the various parts of the body, right? That is your disseminated. And they form, or this tuberculosis form the lesions in different parts of the body, and accordingly the names have been given. So you take the pulse lesion. What is the pulse lesion? Where the presence of the Gons focus in the supraclavicular area, right? Supraclavicular focus, right? Supraclavicular focus in chronic pulmonary tuberculosis is called as the pulse lesion. Next is the Asthma focus. What is Asthma focus? You have the presence of lesion in the infraclavicular area. So infraclavicular focus in chronic pulmonary tuberculosis is your Asthma focus. Then V-gut focus. What is V-gut focus? The presence of caseating metastatic focus in the pulmonary vein. Okay, so V for V-gut, V for vein. Just remember that. Simon focus. Simon focus, it is a calcified focus, right? It is a calcified focus at the apex of the lung. That will be Simon focus. Rich focus, that is the focus in the brain, that is tubercular meningitis. That will be the rich focus. Next is Simon's. Simon is calcified focus at the apex of the lung. Simon's is the tuberculous foci in the liver. Lastly, the Ponson's disease, that we call it, that is nothing but the tuberculous arthritis. Okay, so these are the various lesions. Now, in case of disseminated tuberculosis, what is that you have to remember is, why is it, the another name for it is, it is also called as the miliary tuberculosis. It is also called as the miliary tuberculosis. Now, why is it called miliary tuberculosis? Because if you take the lesions or the opacities within the lung, The lesions or opacities in the lung are of the size of the millet seeds, right? Are of the size of the millet seeds. That is the reason why it is called the miliary tuberculosis. And in case of disseminated tuberculosis, the organism doesn't stay much in the lung. It spreads to the distant organs. So that is the reason why even if you do a sputum examination, there is high chance that the sputum examination may come negative. And the another description of this chest X-ray is, it is also called the snowstorm appearance. Now, what are the other conditions where you can have the snowstorm appearance? One is definitely tuberculosis. The other condition where you can have the snowstorm appearance is, you come across this in case of the silicosis, you come across this in the hemosiderosis, right? And other conditions are the varicella zoster pneumonia, that is the chicken pox, and then pulmonary alveolar proteinosis. These are all the conditions where you can have the presence of the snowstorm appearance. Now, if you take the investigations apart from the chest X-ray, the other important test is the tuberculin test. So, in order to tell the tuberculin test to be positive, how much should be the size of the induration? It should be more than 10 mm. But what are the clinical conditions? This is one of the PYQ. What are the clinical conditions? Even the size of induration is like 6 to 10 mm also, we consider it as positive. Usually it is more than 10 mm, we consider it as positive. But even 6 to 10 mm is positive in conditions like the HIV. Okay. And in patients who are having close contact with tuberculous patient, and the patient who is on immunocompromised treatment or immunosuppressive treatment, the patient who is on steroids, the patient who is on chemotherapeutic drugs. So patient who is on immunosuppressive treatment also, even if 6 to 10 mm induration is there, we consider it to be positive. And so these are the conditions where even 6 to 10 mm of induration we consider as positive. Next is the investigation of choice in case of tuberculosis. The investigation of choice in tuberculosis will be the CB-NAT. What do you understand by the word CB-NAT? That is cartridge-based nucleic acid amplification test. So you take the CB-NAT, you will get this result within 2 to 4 hours. And the advantage of this particular CB-NAT, which is also called gene expert, is it will also tell you about the multi-drug resistance. That means, is the tuberculous organism resistant to isoniazid and rifampicin or not? Even that can also be said by your CB-NAT. And next is, what exactly you mean by multi-drug resistant tuberculosis is defined as resistance to isoniazid and as well as rifampicin. Not only MDR TB, we have another form of TB. Okay. Now, in order to have the development of MDR TB, there should be development of gene mutation. Now, for development of rifampicin resistance, the gene which is being mutated in the organism is RPOB gene. And in order to develop pyrazinamide resistance for the tuberculous organism, the gene that has to be mutated is the PNCA gene. And for the development of INH resistance, the gene that is to be mutated is the INHA gene. So these are the gene mutations which are responsible for the development of the resistance of rifampicin, isoniazid, and as well as pyrazinamide in the tuberculous organism, right? Next is, yes, we have, apart from this, we have another terminology called XDR-TB, that is extended drug resistant tuberculosis. So extended drug resistant tuberculosis means the organism is resistant to the isoniazid, the organism is resistant to rifampicin, and along with this, the organism is also resistant to the second line anti-tubercular drug. The organism is resistant either to capreomycin or the kanamycin, and then amikacin, right? And then amikacin. So this is what is called as the XDR tuberculosis, extended drug resistant tuberculosis, right? Now, next, another important investigation is the sputum examination. So in the sputum examination, you have to use certain stains for eliciting the tuberculous bacilli. And what are those stains? One is the carbalfuchsin stain, which is the nothing but the classical Ziehl-Neelsen stain. And the other one is the fluorochrome stain, that is nothing but your auramine, rhodamine, and as well as the auramine stain. So these are the two stains that can be used to demonstrate the acid-fast bacilli. Okay, next, what is the treatment, right? Everyone is aware of the first line anti-tubercular drugs and second line anti-tubercular drugs and even the regimen. But what is that very important you need to remember here is the new drugs. What are the new drugs for the treatment of the tuberculosis? The new drugs are the pretomanid, right? Then we have bedaquiline, right? We have the bedaquiline. Next is delaminid. Okay, so these are the new drugs for the treatment of the tuberculosis. So these are some of the important points related to your Mycobacterium tuberculosis. Now after this, we'll move on to the discussion of some fungal infections of the lung, that is your aspergillosis. So aspergillus, remember we have two important species. One is Aspergillus fumigatus, the other one is Aspergillus niger. The Aspergillus fumigatus is the one which will be causing the pulmonary aspergillosis. Whereas if you take the Aspergillus niger, that is associated with external ear infection, that is the fungal otitis media. And this is very commonly, this aspergillus infection is very commonly seen in severely immunocompromised patients, right? Severely immunocompromised patients. And particularly if you take this ABPA. So we have four forms of aspergillosis: allergic bronchopulmonary aspergillosis, saprophytic aspergillosis, which is also called aspergilloma, chronic necrotizing aspergillosis, and invasive aspergillosis. Now out of this, if you take this ABPA, that is allergic bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis, it is a hypersensitivity reaction, right? Allergic bronchopulmonary aspergillosis, it is a pulmonary hypersensitivity disorder which is caused by allergy to the fungal antigen that colonizes in the tracheobronchial tree. That is what is your ABPA, right? What is it? It is a pulmonary hypersensitivity reaction. Okay, now this ABPA, it is very commonly seen in the individuals suffering with asthma. These patients, they have the pulmonary infiltrates upon the chest x-ray, and when you check the eosinophil levels, you have the peripheral eosinophilia, and the immediate skin sensitivity test for aspergillus antigen will be positive. There will be elevated serum IgE levels, right? There will be elevated serum IgE levels, and there will be proximal or central bronchiectasis. So these are the main diagnostic criteria. Now, what are the secondary diagnostic criteria? The secondary diagnostic criteria is the sputum. The color of the sputum will be brownish plugs in the sputum. And second is the identification or culture of the Aspergillus fumigatus from the sputum and elevated IgE antibodies specific for the Aspergillus fumigatus. So these are the secondary diagnostic criteria, right? Now, after having discussed about the criteria, like what will be the clinical presentation? Just now we have discussed cough with expectoration, and peripheral blood will show you eosinophilia and as well as elevated IgE levels. Now, yes, you see this question. All of the following are true about bronchopulmonary aspergillosis except central bronchiectasis, pleural effusion, asthma, then the eosinophilia. See, you have to remember a very important point that in case of allergic bronchopulmonary aspergillosis, you don't have the development of the pleural effusion. Whereas central or proximal bronchiectasis can be there, asthma can be seen, and even development of the eosinophilia, right? And yes. And what is the drug of choice for your allergic bronchopulmonary aspergillosis? The drug of, see, it is the immune hypersensitivity reaction. So the drugs that we can be given is the steroids, right? That will suppress the immune hypersensitivity. Okay, so that is your steroids. Next is, you see the other question. A 40-year-old patient with history of prolonged shortness of breath. Chest X-ray shows the presence of diffuse pulmonary infiltrates. Skin hypersensitivity is positive for, right? It is positive for the Aspergillus antigen. The peripheral blood shows the normal eosinophilia, and serum IgE levels, they are normal. What do you think is the most likely diagnosis? Allergic bronchopulmonary aspergillosis, ABPA, extrinsic allergic alveolitis, invasive pulmonary aspergillosis. See, here the very important point is the IgE levels, right? The very important point is IgE levels. So if you take the hypersensitivity reaction to the aspergillus, hypersensitivity reactions to the aspergillus, we divide it into two forms. One is IgE mediated and the other one is non-IgE mediated. See, IgE mediated is that you come across this in individuals with having pre-existing asthma, that to atopic asthma, or IgE levels elevated in case of aspergillus means it will be allergic bronchopulmonary aspergillosis. But in a scenario where the aspergillus antigen is positive but IgE levels are normal, that will be your extrinsic allergic alveolitis. So what exactly is this now? Here it is the extrinsic allergic alveolitis. Why? Because the serum IgE levels are normal. The peripheral blood eosinophils are normal. So that is suggestive of the extrinsic allergic alveolitis, right? Now, so this, and what are all the points in case of extrinsic allergic alveolitis? Remember, they will have the normal IgE levels, right? They will have the normal IgE levels. And you take the peripheral blood eosinophilia. No. So eosinophil levels in the peripheral blood will be absolutely normal. And chest X-ray, you have the diffuse pulmonary infiltrates on the chest X-ray. So this is about your extrinsic allergic alveolitis. Now you take in ABPA. See, what are the various methods by which you can diagnose your allergic bronchopulmonary aspergillosis? One is your peripheral blood eosinophilia, and serum IgE levels are elevated, and serum precipitants or antigens for Aspergillus fumigatus will be there. But you need to know the X-ray in these patients with the allergic bronchopulmonary aspergillosis. So if you take the X-ray in these individuals, you have the presence of bronchiectasis, right? And where is that you have the bronchiectasis predominantly? That is the central bronchiectasis, or the opacities are mainly confined to the upper lobe. The opacities are mainly confined to the upper lobe. But these opacities, they don't just remain only in the upper lobe. These shadows, they move around the upper part of the lung, right? They remain within the upper lobe or upper part, but they move around the upper part of the lung. And that particular type of opacities, we call it as the fleeting opacities. Right, we call it as the fleeting opacities. That is what is the chest X-ray finding in patients with the allergic bronchopulmonary aspergillosis. Now, what exactly is the drug of choice for allergic bronchopulmonary aspergillosis? That is the corticosteroid therapy. That is prednisolone is the drug of choice for allergic bronchopulmonary aspergillosis. Okay, right. Right, now we'll move on to the next topic, that is tropical pulmonary eosinophilia. Right, so I'm very sorry that I'm not going with your comments, like whatever you are typing. So I have already said you, like if you have any doubts, please text me on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Guba, where I'll answer you there. Right, so this will be a break if I want to give any explanation or if I want to clear any doubt for you. Okay, right. So now the next topic is the tropical pulmonary eosinophilia. So tropical pulmonary eosinophilia, you see this important question: all of the following diseases are associated with peripheral blood eosinophilia except, right, all of the following diseases features are or the features of tropical pulmonary eosinophilia except, that is, which is the incorrect statement related to the tropical pulmonary eosinophilia. See, in case of tropical pulmonary eosinophilia, what you have to remember is that this tropical pulmonary eosinophilia, it is a distinct syndrome that develops in individuals infected with lymphatic filarial species, right? Infected with lymphatic filarial species. And this tropical pulmonary eosinophilia, it is more common in males rather than females, right? And these patients, that is males who develop this tropical pulmonary eosinophilia, they have history of their presence in filarial endemic region, right? They have come from the area where there is the filarial endemic region. And what will be the clinical manifestation in these individuals is the presence of the paroxysmal cough and wheezing. And this cough and wheezing, usually it is nocturnal, right? Usually it is nocturnal. And what are the other features in these individuals with tropical pulmonary eosinophilia? Weight loss will be there, low grade fever, and as well as the adenopathy. And what about the eosinophil levels? The eosinophil levels in tropical pulmonary eosinophilia will be more than 3000 cells per cubic millimeter. Next thing is the chest X-ray. So if you take the chest X-ray will show the presence of the increased bronchovascular markings, and there will be diffuse miliary lesions, and there will be also mottled opacities, right? Prominent bronchovascular markings may be there, diffuse miliary lesions, and there will be mottled opacities. That will be the chest X-ray finding. Now, do you see microfilaria in the blood? The answer is no, right? You don't see the microfilaria within the blood. What is that you will see in the peripheral blood is you have the IgE antibody, that is anti-filarial antibody, right? That is the anti-filarial antibody. And when you do a pulmonary function test also, pulmonary function test in case of the tropical pulmonary eosinophilia, which is being caused by infection with lymphatic filariasis, that will show you the presence of the restrictive pattern where your FEV1 by FVC is more than or equal to 70%, right? So the diagnosis of your tropical pulmonary eosinophilia is confirmed by marked elevation of the filarial antibody. It is not the microfilaria in the blood. So microfilaria are generally not detectable in the peripheral blood, right? Not detectable in the peripheral blood. Okay, right. So, and what exactly is your drug of choice for your tropical pulmonary eosinophilia? That is your diethyl carbamazepine. So this diethyl carbamazepine, what is the standard dose? The standard dose for diethyl carbamazepine is 6 milligrams per kg body weight. And so you have to give in 3 doses. You have to give in 3 doses and you have to give it for 12 to 21 days. Okay. So diethyl carbamazepine is active against microfilaria and as well as even the adult worms. So that is about your tropical pulmonary eosinophilia, which is being caused by what? It is caused by individuals infected with lymphatic filarial species. Okay, right. The next important part of the discussion will be the pulmonary function test. So even though these are being dealt in detail in the physiology, but what I'll show you here is some of the image based questions on the pulmonary function test. So what is that instrument with which we measure the pulmonary function test? That is the spirometer, right? Spirometer is the one which we measure the pulmonary function test. But the spirometer cannot measure certain lung functions. What are those? The spirometer cannot measure the residual volume. Spirometer cannot measure the total lung capacity. And this spirometer can also not measure the functional residual capacity. So these are the volumes and capacities that cannot be measured by your spirometer, right? Now, in order to measure this residual volume, total lung capacity or the functional residual capacity, what you require is the body plethysmography. Right? What you require is body plethysmography. Okay, so this is the best test for assessing the residual volume, total lung capacity, and as well as the functional residual capacity as well, right? Now, what is important is, what is the purpose of your pulmonary function test? That is mainly to differentiate obstructive lung diseases from the restrictive lung diseases. That is the important function of your pulmonary function test. And in case of the obstructive lung diseases, how will be the pulmonary functions? And in restrictive lung diseases, what will be the pulmonary functions? So all that, let me just try to show you quickly. So, right, you take in case of the obstructive lung diseases. What are all your obstructive lung diseases? Asthma, bronchiectasis, bronchitis, cystic fibrosis, and COPD. These are all your OLD, obstructive lung diseases. And remember, in case of the obstructive lung diseases, almost all the volumes, right? Almost all the volumes, they are increased. Okay, that means what I mean to say is the capacities. Okay, so total lung capacity increases, residual volume increases, functional residual capacity also increases. Except for this, very important to diagnose that it is an OLD is this one, that is FEV1 by FVC. So FEV1 by FVC, it is decreased. How much it is decreased? It is decreased to as low as 20 to 30%. Normal value is 70%. Right, and other parameters are the peak expiratory flow rate is also being reduced. Okay, next is the DLCO, diffusion capacity of the lung for carbon monoxide. Diffusion capacity of the lung for carbon monoxide is normal in all the forms of obstructive lung diseases except for your emphysema. In emphysema, the DLCO will be decreased. So this is about the story of PFT and OLD. Now you take the restrictive lung diseases. See, what are all the examples of your restrictive lung diseases? You have pulmonary and as well as the extrapulmonary conditions. So what are the pulmonary pathologies that will cause the restrictive lung diseases? That includes sarcoidosis, pneumoconiosis, idiopathic pulmonary fibrosis, and as well as drug or radiation induced interstitial lung diseases. And you also have some extrapulmonary conditions. What are those extrapulmonary conditions? Like diaphragmatic palsy, Guillain-Barré syndrome, muscular dystrophy, where there will be respiratory muscle paralysis, cervical spine injury, and even chest abnormalities like kyphoscoliosis, obesity, ankylosing spondylitis. These are all the conditions where you will have the restrictive lung diseases. And in restrictive lung diseases, let me tell you, like most of the parameters, they are decreased except for your FEV1 by FVC. FEV1 by FVC, it remains normal or increased, whereas you take all other parameters, they are decreased in patients with the restrictive lung diseases, right? So let me just show you the flow volume loops. So in the flow volume loop, this is a normal flow volume loop. So in the flow volume loop, that what you need to know is you have the loop below the y-axis. Okay, yeah, sorry, below the x-axis and above the x-axis. So below the x-axis, that will be the inspiratory component, and above that is in the positive side, that will be the expiratory pattern. Okay, now You can just remember easily. Whenever we are inhaling, the air moves down. So that will be the inspiratory loop lower down. And whenever we exhale, the air moves out. That is exhalation, expiration. So the expiratory volume loop will be above. Okay. Now, this is a normal flow volume loop. Now, how will be the flow volume loop in case of the different pathologies? Like you see this particular flow volume loop. The pattern shown on the flow volume loop is, so now what has been reduced here? It is the expiration which is being reduced. Expiration is classically reduced in case of the obstructive lung diseases. Like in OLD, like you take in patients with asthma, bronchitis, bronchiectasis, cystic fibrosis, COPD, you get this particular type of the flow volume loop where the expiratory component is being reduced. Okay. And the next important is, okay, you see this, the flow volume loop, right? So where only the inspiratory component is reduced, but expiration is normal. You take in case of the restrictive lung diseases, in restrictive lung diseases, both of them are reduced. Inspiration and expiration both are reduced. But in which scenario you get only the inspiration being reduced? You get this in case of the variable extrathoracic obstruction. Like for example, the presence of a retrosternal goiter. So this particular retrosternal goiter, it is an obstructive lesion. So this lesion, this retrosternal goiter, it is being sucked inwards or sucked down when the individual is inhaling. So when the retrosternal goiter is sucked down, when the individual is inhaling, the goiter can compress the airway, thereby the inspiration can be reduced. And whenever the individual exhales, this particular retrosternal goiter moves up and the expiration will be normal. So variable extrathoracic obstruction, you will observe that there is only decrease in your expiration. But whereas you see another important flow volume loop. I'm sorry, one second. Yeah, so only inspiration being reduced is in case of variable extrathoracic obstruction. Okay, now you see the another important flow volume loop. So in this flow volume loop, what is that you are observing? You are observing that only expiration is being reduced, right? Expiration is being reduced, but inspiration is being normal. So you come across this in case of variable intrathoracic goiter, right? Variable intrathoracic goiter, you will have the only the expiration being reduced. And what is that intrathoracic goiter? That is the laryngeal tumor. So laryngeal tumor, that will be a variable intrathoracic goiter where only the expiration will be reduced but the inspiration will remain normal. Now the another condition is the scenario where, right, the scenario where both expiration and as well as the inspiration will be reduced. So you come across this in case of the fixed obstruction of the trachea. What is that fixed obstruction of the trachea? That is in case of the tracheal stenosis, right? In case of the tracheal stenosis. So in case of tracheal stenosis where there is fixed airway obstruction, both inspiration and as well as the expiration is being reduced. Okay, so this is about, yeah, so this is about the all the topics which have been done in the pulmonology. So I did not leave any particular topic in the pulmonology. So almost all the topics are being done quickly in the topic of pulmonology, right? So once we are done with this, we'll move on to, okay, now I have a clinical scenario, right, which is there in your booklet, I mean the PDF which has been sent. Let us try to crack this clinical scenario. Okay, right. So the question is a lengthy question. You should have little patience while reading this question, right? And yes, the basic rule is same. Whenever you get a lengthy clinical scenario, you just read the last sentence. That will tell you what exactly is the question about. What is the most likely cause of the patient symptoms? So basically what he is asking is the etiology of the entire clinical scenario. So a 65-year-old man is evaluated for progressive dyspnea on exertion that has occurred over the course of past 3 months. His medical history is significant for an episode of necrotizing pancreatitis that resulted in multi-organ failure and acute respiratory distress syndrome. So what the patient had developed? ARDS, right? So when was that? That is past 3 months, right? Next, he requires mechanical ventilation for 6 weeks prior to his recovery, right? Prior to his recovery, right? He required 6 weeks of mechanical ventilator. 6 weeks prior to recovery, mechanical ventilator was required. So he also has the history of 30 pack years of tobacco smoking, quitting 15 years previously, and he is not known to have COPD. Not known to have COPD. On physical examination, a low-pitched inspiratory and as well as the expiratory wheeze is heard, loudest over the mid-chest area. On pulmonary function testing, The forced expiratory volume in 1 second is 2.5 liters, that is 78% of the predicted value, right? And forced vital capacity, that is 94% of the predicted value. And FEV1 by FVC ratio, it is around 62.7%. That means it is being reduced. Now the flow volume curve is being shown. What is the most likely cause of this patient? So the options are the aspirated foreign body, chronic obstructive pulmonary disease, idiopathic pulmonary fibrosis, subglottic stenosis, and then unilateral vocal cord paralysis. Okay, now how to solve this question? So if you see here, in this flow volume loop, you are observing that the inspiratory component is reduced and as well as the expiratory component, both have been reduced. Inspiration reduced and expiration is also reduced. Okay, now what has been given in your FEV1 by FVC? FEV1 by FVC is 62.5%, which is suggestive of the obstructive lung disease, right? But what is given in the question? In the question, it is mentioned very clearly that he is not known to have chronic obstructive pulmonary disease, not known to have. Okay, so your COPD, right, we will just keep it as the question mark. We will try to rule out if any other options which can fit this particular the image. So the another important option which can fit this image is the subglottic stenosis. Now, what is the reason why he might have developed this subglottic stenosis causing this decreased expiration and inspiration is because there is history of he required mechanical ventilator for 6 weeks prior to his recovery. So prior to his recovery, he required mechanical ventilator for a prolonged duration of time. And that endotracheal tube which has been placed in the individual might have caused this subglottic stenosis, thereby causing decreased inspiration and expiration. Now you take in COPD, like what did we discuss? It's an obstructive lung disease. So if it is an obstructive lung disease, only the expiration will be reduced, but not the inspiration. So that is the reason why we don't take the option B into consideration. So we consider that it's a fixed stenosis of the airway, which is nothing but your subglottic stenosis, right? So this is about your discussion or rapid revision related to the pulmonology. So now once we are done with the pulmonology, now next we will move on to the quick revision of the GAT. Right, we'll do the quick revision of the GAT. So if you take the GAT topics, just give me a minute. Right. So if you see the rapid revision of the gastroenterology, mainly I have incorporated the hepatology part, right, and as well as that is cirrhosis of liver and its complications. And next important thing which I have incorporated is the viral hepatitis, that is your hepatitis B and hepatitis C, which is very important for your exams. Okay, now let us start with the GAT rapid revision, and the PDF of this has already been posted on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can just go through that. Okay, so, right. So if you see the first clinical scenario, by seeing the image itself, you will be able to answer this question. So what exactly is this suggestive of? This is suggestive of the hepatic encephalopathy, right, where there is the asterixis. But this particular asterixis is not just seen only in case of hepatic encephalopathy. There are many other conditions where you can have the presence of the asterixis. Okay, now you see this question. A 73-year-old man with a history of alcoholism and hepatitis C presents with lethargy and hypersomnia. He has been sleeping all the day and not taking any of his medication. On examination, the patient has ascites, palmar edema, and spider telangiectasia. He also has the flapping motions of his hand when dorsiflexed. Laboratory results revealed a normal ammonia levels. This point is very important to me. Normal ammonia levels. See, whenever there is hepatic encephalopathy, like what do we suspect? We suspect that ammonia levels are very much elevated. But in this patient, normal ammonia levels are there. Now, what is the likely diagnosis? What is the best initial therapy? What is the best initial therapy to reduce the recurrences or improve the quality of life? Okay. Now, so if you see the first important thing, that is the toxic substances. What exactly is that? Alcoholism is there, hepatitis is there, very much suggestive of hepatic encephalopathy. But you take these toxic substances. Definitely, ammonia is one of the most important toxic substance that will be responsible for development of hepatic encephalopathy. But apart from ammonia, you have many other substances like gamma aminobutyric acid, that is your GABA. Next, the other one is the mercaptans. Right, the other one is the mercaptans derived from the methionine. Then short chain fatty acids, right? Short chain fatty acids, then amino acids, then phenol, and we have one more, that is octopamine. So these are the toxic substances which are responsible for the development of your hepatic encephalopathy. So what exactly is the earliest manifestation in hepatic encephalopathy? The earliest manifestation in hepatic encephalopathy is reversal of sleep rhythm, right? Reversal of the sleep rhythm. That means these individuals, they'll have excessive sleep in the morning and reduced sleep in the late night or in the night. So that is the earliest clinical manifestation. Then what is the earliest examination finding? Remember, the earliest examination finding is not your asterixis. It is not your asterixis. The earliest examination finding is a, okay, I'll just show you this image. Yes, right. So the earliest examination finding is constructional apraxia, right? Constructional apraxia. What does that mean? See, you have to draw a simple image. This is you, and you ask the patient to copy the same thing, but he will not be able to do that. That is what is called constructional apraxia. Now, apart next to this constructional apraxia, what are the other examination findings that you can have is this asterixis. Now, this asterixis is not just seen only in hepatic encephalopathy. The other conditions where you can have this asterixis is, you can also see in case of carbon dioxide narcosis. You can also see this in case of uremic encephalopathy. These are the differential diagnosis for your asterixis. Okay. So next is, like, yeah, earliest examination finding is what? Constructional apraxia. Now, what do you think is the most relevant investigation in these patients? See, it is not your serum ammonia levels. Why? Because the serum ammonia levels may appear normal, right? It may be normal. Why? Because there are many other toxins which can cause the hepatic encephalopathy. There are many other toxins which can cause the hepatic encephalopathy. So that is the reason why the most relevant investigation we don't take into the serum ammonia levels. The most relevant investigation what we take is the EEG, that is electroencephalograph. Right, that is electroencephalograph. Now what will this electroencephalograph shows? The electroencephalograph, it will show you the triphasic wave pattern, right? So you have the stages in case of the EEG. So you have stage 4. In stage 4 you have the classical triphasic wave pattern. So this triphasic wave pattern is very, very important in the EEG. Okay, so this is the EEG. So in stage 4 you get this triphasic wave pattern. Okay, and that will be the relevant investigation in these patients with the hepatic encephalopathy. Now, what do you think is the best initial treatment in these patients? The best initial treatment in these patients is you need to give lactulose, right? You need to give lactulose. Now, what is the advantage of giving this lactulose? The lactulose is that which will convert ammonia to ammonium, and ammonium is being excreted out. Okay, so the best initial therapy will be lactulose. Okay, this will convert ammonia to ammonium, right? And what are the other treatment options? The other treatment options that includes rifaximin. What is the purpose of giving this rifaximin, which is an antibiotic? See, rifaximin, it will act as a bacteriostatic agent. Why? Because when you give this rifaximin, it will kill the gut bacteria. Why you want to kill the gut bacteria? Because if there is presence of the gut bacteria, they can cause the fermentation of the food within the intestine, causing increase in the ammonia levels. So we don't want the gut bacteria for a while, so for which you need to give rifaximin. And not only that, the constipation is also a very important risk factor for the development of precipitation of the hepatic encephalopathy. So you also need to give enema to these patients. And next thing is, these patients with hepatic encephalopathy, when liver is gone, there is high chance of bleeding tendencies. So you need to supplement fresh frozen plasma, FFP. And once liver is failed, there is chance of hypoglycemia. So you need to give 10% glucose whenever the individual develops hypoglycemia, right? And another important hepatoprotective agent is LOLA. What is this LOLA? That is L-ornithine, L-arginine, right? L-ornithine, L-arginine. So that is what is your LOLA, which is the hepatoprotective agent. Now we have a form of dialysis called as the liver dialysis. What is this particular liver dialysis is? That is the MARS, M-A-R-S. What is this MARS? That is molecular absorbent reabsorbent system, right? Molecular absorbent reabsorbent system, by which you can take out the toxic substances which have been produced. So this is about the treatment in case of the hepatic encephalopathy. And one question that is being asked previously related to your hepatic encephalopathy is about the precipitating factors. Which of the following is not the precipitating factor for hepatic encephalopathy in patients with the chronic liver disease? Hypokalemia, hyponatremia, hypoxia, metabolic acidosis. Please remember, metabolic acidosis will not cause your precipitation of the hepatic encephalopathy. It is your metabolic alkalosis which can precipitate the development of the hepatic encephalopathy. And you have many other precipitating factors. What are the many other precipitating factors? That is the gastrointestinal bleeding, then excessive dietary intake of protein, then constipation, right? Then constipation. Next, azotemia, right? Next is the azotemia. So azotemia is that where there is increase in urea and creatinine, but there is no clinical manifestation. Next, the other conditions are the hypokalemia can also precipitate the development of hepatic encephalopathy. Next, metabolic alkalosis can also precipitate the development of hepatic encephalopathy. Hypoxia can also precipitate. Then hyponatremia can also precipitate the development of hepatic encephalopathy. So these are some of the important points related to the hepatic encephalopathy. So you need to know the treatment. So what is the immediate treatment that you can give is the lactulose. Okay, what this lactulose will do? It will act as an ammonia binder. That means it will convert the ammonia to ammonium, and ammonium is being excreted out. Okay, and earliest sign, that is the alteration of the sleep wakefulness cycle. And what is the earliest symptom? Earliest sign will be the constructional apraxia, and these patients, they will also have aphasia that is called anomic aphasia. Anomic aphasia is like difficulty in naming the object, right? Difficulty in naming the object. So this is, and what is the reliable investigation? That will be EEG, that will be showing the triphasic wave pattern in stage 4, right? Triphasic wave pattern in stage 4. Okay, right. So once we are done with this topic of the hepatic encephalopathy, we'll move on to the next important topic in the GIT. Right. So what do you think is the answer here? The same thing. Symmetric high voltage triphasic slow wave pattern in EEG is seen in which condition? It is seen in patients with the hepatic encephalopathy. Okay. Right. This is one of your PYQ. Right. Now this is a very, very important clinical scenario. So the clinical scenario is a 47-year-old man with chronic alcoholism presents with abdominal pain and fever. Right. Presents with abdominal pain and as well as the fever. And he has multiple admissions for variceal bleed and ascites requiring large volume paracentesis, right? So multiple times he has undergone large volume paracentesis. The pain is diffuse and has been getting worse since yesterday, right? Pain in the abdomen. He also has fever, chills and rigors. On examination, he has diffuse tenderness over the abdomen with shifting dullness and fluid wave. So what is the most likely organism which is responsible for this clinical scenario? E. coli, staph, Salmonella typhi, the Legionella. So what exactly is the diagnosis? First of all, the diagnosis here is the spontaneous bacterial peritonitis. And what would be the cause for that SBP? That is because of the repeated paracentesis what you are doing for the ascites what the patient is developing. And the most common causative organism for the development of spontaneous bacterial peritonitis will be the Escherichia coli. So this Escherichia coli, it is a gram-negative organism. Next to this Escherichia coli, the another important gram-negative organism will be the Klebsiella pneumonia. Next is, we also have gram-positive organisms. These gram-positive organisms will be the strep pneumonia. Right, the gram-positive organism will be the strep pneumonia. Right, so these are the organisms which are responsible for the development of the spontaneous bacterial peritonitis. Now, in order to diagnose, so most common organism is what? E. coli. Right, now the clinical features will be fever and as well as abdominal pain. Now what is the accurate diagnostic test? The accurate diagnostic test is paracentesis, right? Paracentesis. So in that paracentesis, if you do the levels of your WBC, the level of the WBC will be more than 500 cells per cubic millimeter, right? Or if you take only polymorphs, that is neutrophils. So if you take the polymorphonuclear leukocytes, that will be more than 250 cells per cubic millimeter, and even the protein content will be increased. The protein content of 1 gram can also be there. Okay, right. So that is what is the accurate diagnostic test is what? That is paracentesis, where you need to check for the WBC and as well as polymorphonuclear leukocytes. Now, what is the antibiotic therapy that you need to give? You need to give the drug of choice as the third generation cephalosporin. And this third generation cephalosporin, either you need to give ceftriaxone or the other important drug will be cefotaxime, right? Ceftriaxone or cefotaxime. Okay. Now, if the patient develops the liver failure, right? If the patient develops the liver failure, see, in patients with spontaneous bacterial peritonitis in the setting of acute or chronic liver failure, the treatment should be done with meropenem. Here, we don't give ceftriaxone. What we give is meropenem, right? What we give is meropenem and daptomycin is being recommended. Meropenem and daptomycin is being recommended. So that is about your SBP, spontaneous bacterial peritonitis. And one of the very important area where frequently questions have been asked is on the topic of the assessment of liver CVRT. That is MELD score, many times question asked. What is DF score and what is this child pug score? See, what they will ask you is the parameters or the variables which are included in your score, right? So, which among the following is not the variable or clinical parameter for MELD score? Which among that is not the part of your child pug score? What is the requirement of calculation of the DF score? All that we will discuss now. So, now coming to the MELD score. So, what exactly is your MELD score? That is model for end stage liver disease. That is what is your MELD score. Now, what are the parameters which are included in this is, that is the serum bilirubin, serum creatinine, and as well as the international normalized ratio for prothrombin time to predict the 3-month survival. So, these are the parameters which are included in your MELD score. So, to confuse you, and one more, so to confuse you, what they will add in your options is albumin. So, there is very high chance that we get tempted to albumin because we know that albumin is synthesized in the liver. So, we may assume that because there is like liver injury, so the albumin levels may be reduced and that might be the parameter of your MELD. No, it is not the part of your MELD score. Now, this MELD score will assess the severity of the or mortality of the patients with the cirrhosis of liver. That is, so if the MELD score is like 40 or more, then the chance of mortality is 71.3%. And if MELD score is 30 to 39, mortality is 52.6. And if MELD score is less than 9, the mortality is 1.9%. So, and if suppose when you calculate the MELD score and the MELD score is like more than 14, he is the candidate who has to undergo liver transplantation. That is orthoptic liver transplantation. This particular patient has to undergo if the MELD score is more than 14. Okay, and in orthoptic liver transplantation, HLA matching is not mandatory. HLA matching is not mandatory. Okay, that is about your MELD score. Next one is your DF score, that is discriminant function score. Now, what are the parameters which are there in your discriminant function score is, number 1, serum bilirubin. Next is the international normalized ratio. And when you calculate this DF score, that is discriminant function score, if the score is like more than 32, first of all, in which scenario we calculate this DF score? We calculate this DF score in patients with alcoholic hepatitis, right? In order to assess the severity of alcoholic hepatitis. In order to assess the severity of the alcoholic hepatitis, we calculate this discriminant function score. Okay. Now, if this discriminant function score is like more than 32, it is an indication that you need to give steroids. It is an indication that you need to give steroids or you need to give pentoxifillin. Right? You need to give pentoxifillin. So that is what is your DF score, discriminant function score. Okay, right. And the next important score is the child pug score. The next important score is the child pug score. Now, if you take this child pug score, why is it being calculated? Even this also is calculated for assessment of severity in cirrhosis of liver. See, DF score in alcoholic hepatitis, MELD score, even this also in cirrhosis. So both of these are in the cirrhosis. Now you take child pug score. What are the parameters which are included in the child pug score? So the parameters which are included in the child pug score is bilirubin, albumin, ascites, asterixis and INR. And if the score is like more than or equal to 7, he is a candidate who require the liver transplantation. He is a candidate who require liver transplantation. So this is about your the scoring systems for assessment of the severity of liver disease, that is cirrhosis and as well as the alcoholic hepatitis. Okay, right. So next important topic in the liver that you need to know is, you see this question. A 49-year-old alcoholic man presents with hematemesis that began 2 hours ago. He was intubated for airway protection. His past medical history, right, because he came in the altered sensorium and he had like severe hematemesis and he was intubated for airway protection. His past medical history is significant for hepatitis C infection that has not been treated. He consumes 1 bottle of whiskey a day and he is tachycardic of heart rate of 140 per minute with a blood pressure of 99/68 millimeters of mercury. Dried blood is seen in the oral cavity and palmar erythema is present, which is all suggestive of your liver cell failure. Telangiectasia are seen over the thorax, which are nothing but your spider nevi. That is due to increase in your estrogen level in cirrhosis of liver. AST and ALT shows 100:56, elevated. Prothrombin time is like 24, that is also elevated. Hemoglobin 6 grams per deciliter. What is the next best step in the management of this patient? IV fluids and blood products, octreotide, endoscopic band ligation, tips. So what the question is very clear. What is the next best management? So what you have to understand here is, what exactly is this clinical scenario suggestive of? This clinical scenario is suggestive of the esophageal varices which has been ruptured, right? Esophageal varices which have been ruptured, and because of which the individual is having hematemesis. How can you tell that the patient that developed esophageal varices, he is having a significant hepatitis C infection? And the other important point is, he is a chronic alcoholic. So he has developed cirrhosis of liver, and secondary to cirrhosis of liver, the patient has developed portal hypertension, and secondary to portal hypertension, the patient has developed what? The esophageal varices which has ruptured, causing hematemesis. Now, whenever the patient presents to you in this format, the first best management is the IV fluids and blood products. It is not your octreotide, right? It is not your octreotide. So you have to ensure that the blood pressure of the individual is being maintained. So IV fluids and the blood products are the first best important method, first best management. So what is the diagnosis in this clinical scenario? That is acute GI bleed secondary to rupture of the varices, right? Secondary to the rupture of varices. Now, what is the next best step? What is the best initial therapy? What is the most appropriate therapy? How to control the bleeding? And what exactly will be the discharge advice? So this patient actually had developed portal hypertension. Now to call it as portal hypertension, how much should be the portal venous pressure? So if you take the portal venous pressure, right, normal portal venous pressure will be 5 to 10 millimeters of mercury. That will be the normal portal venous pressure. But to call it as portal hypertension, right, the portal venous pressure should be more than 10 millimeters of mercury. Right, portal venous pressure should be more than 10 millimeters of mercury. Okay, now the point is, this patient definitely developed portal hypertension. Now, what are the other manifestation of the portal hypertension? One is your esophageal varices. The other one is surrounding the umbilicus, like you have that starry appearance which is called as the caput medusae. So caput medusae is nothing but dilated veins surrounding the umbilicus. And next important feature of your portal hypertension is the rectal hemorrhoids. Why is that rectal hemorrhoids? Because this portal vein, it has anastomosis with the rectal veins. So when the portal venous pressure is increased, even the rectal veins, they get enlarged. So thereby you have the development of rectal hemorrhoids. And what exactly is the investigation of choice in patients with the portal hypertension? Investigation of choice in portal hypertension will be the ultrasonography. That is, Doppler ultrasonography should be done. But what is the reliable sign? Right? What is the reliable sign of the portal hypertension? The reliable sign of portal hypertension will be splenomegaly. Splenomegaly is the reliable sign for diagnosis of the portal hypertension, right? Now, what is the next best step in this particular patient who is undergoing bleeding? So, immediate resuscitation, right? Immediate resuscitation with IV fluids and blood products, that is the fresh frozen plasma should be given. Right? Why? Because the patient is unstable. He is hemodynamically unstable. Now, what do you think will be the best initial therapy once the individual is being stabilized? Once the individual is being stabilized by giving your IV fluids, then you need to give a somatostatin analogs, and that somatostatin analogs that you can give is the octreotide. You need to give is octreotide. Okay. Now, what is the other options? Next to your octreotide, the other options that you have is the terlipressin. The other options that you have is the terlipressin. Okay, terlipressin. Okay. Now, but if suppose what has been given in your CMDT 2022 is that between this terlipressin as well as octreotide, in countries where there is terlipressin being available, terlipressin is being preferred over the octreotide. Right? Terlipressin is being preferred over the octreotide. And where is this reference from? This particular reference is from CMDT 2022. Right? So previously, like what all we were discussing was octreotide as a drug of choice. But CMDT 2022 says that terlipressin is maybe preferred to octreotide for the treatment of bleeding related to the portal hypertension. Okay? Right. Next is the most appropriate therapy. Best initial therapy will be this. Most appropriate therapy will be esophageal variceal ligation or esophageal band ligation. That means it is nothing but your endoscopic band ligation. So endoscopic band ligation, in which the bands are placed over the bleeding veins to cause the tamponade effect, right? To cause this tamponade effect. Now, if the bleeding cannot be controlled, in case the bleeding cannot be controlled, then in such case, you need to do a balloon tamponade. And this particular balloon tamponade is being done with Sengstaken Blackmore tube. Right? With the help of Sengstaken Blackmore tube, the bleeding can be controlled. Right? So, how to control the bleeding? That is by balloon tamponade. Right? Then, what is the discharge advice? See, discharge advice is that you have to ensure that the portal venous pressure is, right, the portal venous pressure is less than 10 millimeters of mercury. So for that, the drug which will reduce the portal venous pressure will be a non-specific beta blocker, and that non-specific beta blocker that we can give is propranolol, or the other important drug will be nadolol. Right, the other important drug will be nadolol. Okay, so that is about your treatment for portal hypertension causing the esophageal variceal bleeding. And the another important treatment option, if the individual is having recurrence, then you can do what is called as the TIPS. Right, so what exactly is your TIPS? The TIPS is nothing but transjugular intrahepatic portosystemic shunt. That means what you will do here, you will connect the branch of the portal vein to the branch of the hepatic vein. Right, you will connect the branch of the portal vein to the hepatic vein. Okay, and thereby what is that you are doing? You are directly connecting the portal vein to the hepatic vein and making the portal venous blood directly entering into the hepatic vein, not entering into your liver. Right, not entering into your liver. So thereby your portal venous pressure can be reduced, because the portal venous blood will enter into hepatic vein, and from there it will enter into the inferior vena cava. Right, so that is about your TIPS, that is transjugular intrahepatic portosystemic shunt. Now, the next important thing in the GAT that you need to know is about the ascites. Right, next is about the ascites. Now, what is the criteria, or when is that we use the terminology called abdominal compartment syndrome? Right, what should be the abdominal pressure to call it as abdominal compartment syndrome? See, in case of the abdominal compartment syndrome, the individual can develop wet gangrene. Right, why there is development of your abdominal compartment syndrome in patients with cirrhosis of liver? That is because of ascites. And if the quantity of the fluid which is being accumulated in the peritoneal cavity is like huge, then in such case the fluid can compress. Right, the fluid can compress the circulation of the blood to the visceral organs. Right, and thereby once the circulation of the blood to the visceral organs is being reduced, the individual can develop wet gangrene. This is an emergency now. So what is the criteria? So to call it as abdominal compartment syndrome, the pressure should be around 20 millimeters of mercury. The pressure should be around 20 millimeters of mercury to call it as abdominal compartment syndrome. Now, the very, very important point is, what should be the quantity of the fluid? Let me discuss this entire component of the ascites. What should be the quantity of the fluid to call it as ascites? when the quantity of the fluid which is accumulated in the peritoneal cavity is like more than 25 ml, we call it as ascites. Now, USG abdomen can detect the ascitic fluid up to 100 ml. Right? USG abdomen can detect the ascitic fluid up to the 100 ml. And the Puddle sign. Right? This is an important image-based question. This is your Puddle sign. So, Puddle sign can detect the quantity of the fluid up to 120 ml. Right, the quantity of the fluid up to 120 ml, and this should be the position of the patient whenever you are eliciting the Puddle sign, where the fluid will get accumulated in the central part of the abdomen and where you will get the dull note in the central part of the abdomen, and in the flanks you get the tympanic note. So that is what is your Puddle sign. The next important is, so Puddle sign will be positive when the quantity of the fluid is around 120 ml. Next important is the shifting dullness. So what should be the quantity of the fluid for you to get the shifting dullness? The quantity of the fluid should be around 500 ml to develop the shifting dullness. That is simple. You shift the patient on one side, the fluid will be shifted from one flank to the other flank. So thereby you get the tympanic note on the opposite side and you get the dull note on the side where the individual has been slept. Okay, right. So that is your shifting dullness. Next is the fluid thrill. So when will the fluid thrill will be positive? The fluid thrill will be positive when the quantity of the fluid is around 1 to 1.5 liters. Right, when the quantity of the fluid is around 1 to 1.5 liters, that is the point when the fluid thrill will be positive. So these are some of the important points, like when, so shifting dullness, like 500 ml fluid should be there. The fluid thrill, you will have, the fluid should be around 1 to 1.5 liters. Okay, next is, when do you call the terminology called as intra-abdominal hypertension? Right, intra-abdominal hypertension, to call this, the intra-abdominal pressure should be more than 12 millimeters of mercury. Right, and compartment syndrome, when will you call compartment syndrome? Compartment syndrome, the pressure should be more than or equal to 20 millimeters of mercury, and in this compartment syndrome there can be kinking of the blood vessels supplying to the visceral organs, and thereby there can be development of wet gangrene. Right, next, tense ascites. When do we use the terminology called tense ascites? When the quantity of the fluid in the abdomen, in the peritoneal cavity is huge, where the fluid thrill is also absent. The quantity of the fluid is like more than 1.5 liter. The fluid thrill is absent. Right, the fluid thrill is absent. Why? Because the fluid which is accumulated in the peritoneal cavity is like jam packed. That is causing the tense ascites. That is the reason why the fluid thrill will be absent. And in these patients with this ascites, how will be the umbilicus? The umbilicus is like ballooned out. The umbilicus is like ballooned out. So this is about your ascites story. And next is about the SAG. Right, next is about the SAG. That is serum albumin ascitic gradient. Right, so if the SAG is like more than 1.1 on fluid analysis, that tells you that the patient is having the portal hypertension causing ascites. And if the SAG is like less than 1.1, that means there is no portal hypertension, but there is development of ascites. So this is the importance of your SAG. More than 1.1, it is secondary to portal hypertension. Less than 1.1, it is not portal hypertension, but some other causes causing this ascites. Okay, so this is about the story related to the ascites component. Now then we have two more syndromes that you need to know in the cirrhosis of liver, that is hepatopulmonary syndrome and hepatorenal syndrome. Now you take this question on the hepatorenal syndrome. Okay, so you see this, which of the following should be avoided in case of the hepatorenal syndrome? So octreotide, terlipressin, diuretics, and as well as the norepinephrine. So first of all, what exactly is your hepatorenal syndrome? It is the complication which is seen in 10% of patients with advanced cirrhosis and as well as the ascites. And in these patients with the hepatorenal syndrome, there is renal failure. Right, there is renal failure with normal tubular function. Right, there is renal failure. Right, what is the criteria is that there is development of renal failure with normal tubular function of the kidney. And these patients' kidney, if you do histology, histologically these kidneys are absolutely normal. Right, and the renal failure, whatever it is being developed, it is the functional renal failure. It is a functional renal failure. And the pathogenesis for the development of this hepatorenal syndrome is the splanchnic vasodilatation that occurs in severe stages of cirrhosis of liver. Splanchnic vasodilatation that causes a reduction in the effective arterial blood volume, and because of decrease in the effective arterial blood volume, there is decreased mean arterial pressure, and thereby there can be decreased renal perfusion. So it is like completely the functional failure. Okay, and what are the precipitating factors for the development of hepatorenal syndrome? That is gastrointestinal bleeding, then sepsis can cause hepatorenal syndrome, then even diuretic therapy can cause the hepatorenal syndrome. That is the reason why diuretics are not given in these patients with the hepatorenal syndrome. And the another important precipitating factor is aggressive paracentesis, right? Aggressive paracentesis. Okay, next, then next important thing is the criteria to call it as the hepatorenal syndrome. See, it is characterized by the azotemia, right? So what do you mean by the word azotemia? So azotemia means that there is increase in your serum creatinine. And how much should be that increase in serum creatinine? Increase in serum creatinine should be more than 0.3 milligrams per deciliter within 48 hours. Right? So within 48 hours, there should be increase in serum creatinine greater than 0.3 milligrams per deciliter. So that is one of the criteria to call it as the hepatorenal syndrome. And the next important is, to call it as hepatorenal syndrome, the patient should not be on any of the nephrotoxic drug, right? There should be absence of nephrotoxic drug intake, and there should be absence of structural kidney injury. There should be absence of shock. Then only we use the word the hepatorenal syndrome. And this hepatorenal syndrome, the clinical manifestations will be in the form of the low urine output. Low urine output. And once there is low urine output, the individual will develop what is called dilutional hyponatremia, right? Next, the other point is the types. We have two types of hepatorenal syndrome, type 1 and as well as type 2. See, type 1 hepatorenal syndrome is that where there is acute kidney injury. So acute kidney injury, which is formerly type 1 hepatorenal syndrome, in this there is doubling, right? In this there is doubling of serum creatinine to a level greater than 2.5 milligrams per deciliter. So the creatinine level will be more than 2.5 milligrams per deciliter. So there is doubling of the serum creatinine level, or there is decrease in the creatinine clearance, right? Whereas hepatorenal syndrome type 2, that will be chronic renal failure. That will be your chronic kidney injury. Okay, that is what is your hepatorenal syndrome type 2. Here, hepatorenal syndrome type 2, it is slow and it is progressive. Whereas hepatorenal syndrome type 1, that will be the acute kidney injury. So that is the reason why hepatorenal syndrome type 1, it has the worst prognosis than compared to that of the hepatorenal syndrome type 2. So what is the treatment that you have to give in this patient is, you need to give intravenous terlipressin. You need to give intravenous terlipressin. So this terlipressin, this is like approved for the treatment of hepatorenal syndrome, and the other drugs are, you can give norepinephrine or you can give midodrine, right? You can also give midodrine. So that is the treatment for your hepatorenal syndrome. But what is the ultimate treatment if these individuals develop hepatorenal syndrome recurrently? The ultimate treatment will be TIPS, that is transjugular intrahepatic portosystemic shunt. So that is about your hepatorenal syndrome, which is one of the very, very important complications in severe forms of the cirrhosis of liver. Okay, and the other option apart from the TIPS will be liver transplantation. That is also the another important option which is being available. Okay, that is hepatic or liver transplantation. Okay, so with this we are done with the topic of the hepatorenal syndrome. Next is the hepatopulmonary syndrome. Okay, so hepatopulmonary syndrome is that where through small communications within the diaphragm, the fluid from the peritoneal cavity can enter into the pleural space, causing compression of the lung parenchyma. So these patients with hepatopulmonary syndrome, they develop what is called platypnea. Right? What is platypnea? So platypnea is that the individual in sitting posture, they will have dyspnea. Right? They'll have dyspnea in sitting posture. But the same patient, whenever he lies down in supine position, the dyspnea will disappear. The dyspnea will disappear in supine posture. That is what is called as the platypnea. That is what is called as platypnea, right? Or we call it as platypnea orthodeoxia syndrome. platypnea orthodeoxia syndrome, right? Now, in order to diagnose, okay, so in order to diagnose, one second, right, in order to diagnose this hepatopulmonary syndrome, what is the triad? There is a clinical triad. The triad of hepatopulmonary syndrome is that number one, chronic liver disease, number two, increased alveolo-arterial gradient while the patient is in breathing room air. Third one is there is intrapulmonary vascular dilatation, right? There is intrapulmonary vascular dilatation. Okay, so this is a triad: chronic liver disease, increased alveolo-arterial gradient when the patient is in like room air, and intrapulmonary vascular dilatation. So this is a triad of the hepatopulmonary syndrome. Now the presentation will be platypnea orthodeoxia, right? And the diagnosis should be suspected. When will you consider hepatopulmonary syndrome? You will consider hepatopulmonary syndrome in a cirrhotic patient with pulse oximetry showing saturation less than 94%. When saturation is like less than 94% in a patient who is having cirrhosis, then you need to suspect the hepatopulmonary syndrome. Now, what is the investigation of choice, right? What is that which will confirm the diagnosis of the hepatopulmonary syndrome? The methodology by which you can confirm the hepatopulmonary syndrome is by doing an investigation called macro aggregated albumin lung perfusion scanning, right? So macro aggregated albumin, A stands for albumin lung perfusion scanning, that is MALP, macro aggregated albumin lung perfusion scanning. And this is more specific and may be used to confirm the diagnosis of hepatopulmonary syndrome. And the another important sensitive screening test. So what will be the screening test for hepatopulmonary syndrome? That will be contrast enhanced echocardiography, right? So that will be the screening test. What it will show you, that will detect the presence of pulmonary vascular dilatation, right? Your contrast enhanced echocardiography will detect the presence of pulmonary vascular dilatation. But what is that which will confirm the diagnosis? That is MALP, that is macro aggregated albumin lung perfusion scanning, right? Now what is the treatment in these patients? So as such, the prognosis is not good, right? These patients, they require long-term oxygen therapy. Long-term oxygen therapy, so treatment is long-term oxygen therapy, right? That is being advised. And this particular hepatopulmonary syndrome may reverse with liver transplantation. So when you do liver transplantation, that is the point when the hepatopulmonary syndrome can get reversed. Okay, so this is about your the complications in patients with the cirrhosis of liver, one of the very important area where the questions have been frequently asked in the hepatology, right? Next, so okay, so subsequently I will just take a break for 5 to 10 minutes, right? We'll just take a break for 5 to 10 minutes, then we'll reassemble and discuss the other important topics in the hepatology like autoimmune hepatitis, then viral hepatitis, that is your hepatitis B, and as well as hepatitis C, and subsequently we'll try to discuss the infectious diseases. Just take a break for 10 minutes. right? So the next topic for the discussion now in the gastroenterology is the autoimmune hepatitis. So autoimmune hepatitis, as the word itself tells you, it is an antibody which is being formed against the liver. Now we have three important forms of autoimmune hepatitis, that is type 1, type 2 and type 3 autoimmune hepatitis. So in all of these you have the characteristic, the autoantibody profile which is being present. So you take in case of the autoimmune hepatitis type 1, the characteristic autoantibody profile is the anti-nuclear antibody will be positive and as well as the smooth muscle antibody will be positive, SMA will be positive. Whereas in case of the type 2 autoimmune hepatitis, the characteristic autoantibody profile will be anti-LKM antibodies, right? That is liver, kidney, then microsome 1 antibody. So that is anti-LKM1 antibody. Then you take type 3 autoimmune hepatitis. Type 3 autoimmune hepatitis is that where the characteristic autoantibody profile is anti-SLA, right? That is anti-SLA. So anti-SLA, it stands for soluble liver antigen, right? And even your SMA, that is smooth muscle antibody, is also positive. So that is what is in case of type 3 autoimmune hepatitis, right? Next, so after having discussed about these three types of autoimmune hepatitis, now let me take up the other laboratory findings. So when you are using the word hepatitis, right, the important parameter is the enzyme, that is the serum aminotransferases, that is AST and ALT, will be elevated more than 1000 units per liter, right? AST and ALT will be more than 1000 units per liter, and even the total bilirubin levels also will be elevated. So this is about your autoimmune hepatitis. And what is the treatment? So when you are using the word autoimmune, you should give the immunosuppressive agents, and that particular immunosuppressive agent that you need to give is the prednisolone, and this prednisolone should be given with or without azathioprine, right? This should be given along with or without the azathioprine. Okay, so this when you start this prednisolone with or without azathioprine, this will improve the symptoms of the individual. This will decrease the serum bilirubin, this will decrease the serum aminotransferase, this will decrease the gamma globulin levels. Okay, and not only that, this prednisolone will also reduce the hepatic inflammation as well. Now, so definitely yes, the very important group of drugs is prednisolone with or without the azathioprine. But in those individuals who are non-responders, in those individuals who are non-respondent, not responding to corticosteroids and azathioprine, you have given corticosteroids and azathioprine, but there is no response. So in these individuals with autoimmune hepatitis, the other alternative drugs that you need to try is you need to give the trial of cyclosporin or tacrolimus or right, or the sirolimus, right, or the everolimus. So these are the, or the other drug is methotrexate. The other drug is methotrexate. So these are the alternative drugs that you need to give if the patient does not respond to corticosteroid and as well as azathioprine. So this completes the discussion of your autoimmune hepatitis, right? So three types you have to remember: type 1, type 2, type 3, and that antibody profile is also very, very important. In case of type 1 autoimmune hepatitis, it is your anti-nuclear antibody and as well as the smooth muscle antibody. Whereas in case of type 2, it is anti-LKM1 antibody. Whereas type 3, you have anti-SLA and as well as the smooth muscle antibody, right? Now, then followed by that, you need to know about the viral hepatitis. So viral hepatitis, what is very, very important is like you have A, B, C, D, E. Out of which are very, very important for your exam is your B and as well as C. But anyways, I'll just give you a quick recap of all the forms, and in detail, I'll discuss about the B and as well as C. So you can just see this question. All these human hepatitis viruses are RNA viruses except. So which among this is not the RNA virus? That will be your the hepatitis B virus. So hepatitis B virus, it is the DNA virus. The remaining all the viral hepatitis virus except hepatitis B, you have the RNA, right? You have the RNA. Next, and you have a new variant of, right? You have a new variant of the viral hepatitis that is called the hepatitis G. But this particular hepatitis G, it does not cause the human hepatitis, right? It has been found to show the hepatitis in the animals, but in humans, it does not cause the hepatitis, that is hepatitis G. Now, let us take up the discussion particularly on hepatitis B. Okay, or before going on to the hepatitis B in detail, let me just take up some of the single liner questions on all the forms of the hepatitis. So you see this question, the most common virus associated with transfusion associated hepatitis, the most common virus which is transfusion associated hepatitis will be the hepatitis B virus and as well as the hepatitis C virus, right? These are the most common viruses associated with transfusion associated viruses. And vaccine or prophylaxis is not available for which form of the viral hepatitis? That is hepatitis C virus, right? There is no vaccine or the prophylaxis which is available. And malignant potential among all these viral hepatitis, it is more common for hepatitis C virus, then followed by that the hepatitis B virus. And progression to chronicity is seen in case of the hepatitis B virus and as well as the hepatitis C virus, right? Progression to chronicity is seen in hepatitis B and hepatitis C virus. And perinatal transmission, right? Perinatal transmission is most significant for the hepatitis B virus. What is perinatal transmission? That is vertical transmission, mother to fetus. It is more common in case of hepatitis B. Whereas which are the forms of viral hepatitis which are being spread by the parenteral routes, that is your IV or subcutaneous or needle prick, that will be your B, C and as well as D. Whereas your hepatitis A and E, that will be non-parenteral route, right? What will be that non-parenteral route? That means they are being spread by the feco-oral route, right? They are being spread by feco-oral route. Which one? A and as well as E. Now, if you take the hepatitis B virus, it is not being transmitted through feco-oral route, right? It is not being transmitted through the fecal-oral route. And the most common hepatitis that progresses to chronicity, right? Remember, C for chronicity, C for hepatitis C, right? And most common cause of fulminant hepatitis in pregnant women, that will be the hepatitis E. And most common cause of epidemic and as well as sporadic hepatitis, both of them, it will be the hepatitis E. And the most common cause of sporadic hepatitis in children, that will be hepatitis A, right? That will be hepatitis A. Okay, so this is about the various forms of the hepatitis and important questions related to your viral hepatitis. Now let me take up detailed discussion related to the hepatitis B, right? Detailed discussion related to the hepatitis B. So if you take this question, that is the liver biopsy in acute hepatitis due to hepatitis B virus is likely to show all of the following except ballooning changes of the hepatocyte. Second option, ground glass hepatocytes. Third option, focal or spotty necrosis. Fourth option, acidophilic bodies. Right? Now, ballooning change of hepatocytes will definitely be there. Right? That is what is nothing but your ballooning degeneration. Then coming to cytolysis, there will be necrosis of the hepatocytes. And there will be presence of acidophilic bodies, and these acidophilic bodies, they are called as the councilman bodies, right? They are called as the councilman bodies. Okay, so these particular councilman bodies are also seen, but the one which is not seen is the ground glass hepatocytes will not be there in patients with the acute hepatitis, right? Next, now if you move on to the other questions related to the viral hepatitis, yes, which of the following hepatitis virus has significant perinatal transmission? Just now we have discussed. That is, your hepatitis B has a very significant perinatal transmission. That is from mother to fetus. Now, next to this, you need to know about the serology. Or before going on to the serology, let me just give you a quick recap of the acute hepatitis and then we will move on to the chronic hepatitis. So, if you take this acute hepatitis, these patients, they have the prodromal symptoms. Right? What will be the prodromal symptoms? The prodromal symptoms in case of acute hepatitis will be anorexia, nausea, vomiting, fatigue, malaise, myalgia, fever. These are the prodromal symptoms, right? Fever, myalgia, fatigue, nausea and vomiting. So these are the clinical features. But on examination, what is that you will see in case of acute hepatitis is you will have that clinical jaundice. And even the urine also a dark urine, and the stool will be clay colored stool will be there. And because of this hepatitis, when you try to apply the pressure over the right hypochondrium, you will notice that there is tender hepatomegaly in the right upper quadrant. And in case of this acute hepatitis, the enzymes are elevated, right? The enzymes are elevated. Which enzymes? The ALT is more elevated than compared to that of AST in case of hepatitis. But whereas you take in case of alcoholic hepatitis, the pattern is exactly reverse. In case of alcoholic hepatitis, it is AST which is more elevated than compared to that of ALT. Whereas in case of acute viral hepatitis, it is ALT that is more elevated than compared to that of the AST, right? So this pattern is a very, very important question. And the other enzymes which are elevated in acute hepatitis is the alkaline phosphatase levels are elevated. But so alkaline phosphatase levels, they are elevated. But one point that you have to remember is that about the albumin. In case of acute hepatitis, the albumin levels, they remain normal because albumin, the half-life is up to 21 days. So the albumin level will not be reduced in case of the acute viral hepatitis. They are like usually normal. Okay, so these will be the features of the acute hepatitis. The jaundice, the icterus, what is the site where the icterus appears first? So when will the icterus appear? First of all, the icterus will appear when the serum bilirubin level is more than 2, and the icterus first appears over the tongue frenulum. Over the tongue frenulum, you need to observe for that yellowishness, and followed by the tongue frenulum, you observe within the sclera. Why within the sclera? Because the elastin which is present in the sclera, it has a very good affinity for bilirubin. So that is the reason why jaundice is actually first detected by seeing the sclera. But actually the yellowishness, where exactly it appears first, that will be in the tongue frenulum. That will be in the tongue frenulum. Okay, right. So this is about your acute viral hepatitis. Now followed by this, and one more important thing in case of acute viral hepatitis that you need to know is the USG abdomen. So when you do a USG abdomen in case of acute viral hepatitis, there will be increase in the liver span, right? There will be increase in the liver span, and not only that, right? Not only that, the ultrasound liver will show a characteristic echo texture. What is that characteristic echo texture that can be seen in case of viral hepatitis is you will have the ultrasound showing the characteristic starry sky appearance, right? Showing starry sky appearance. But this particular point of starry sky appearance is not just seen in only viral hepatitis. This starry sky, you take where all you can get starry sky appearance, lymph node biopsy showing starry sky appearance. You can get this in Burkitt's lymphoma. Kidney biopsy showing starry sky appearance. You get this in case of post-streptococcal glomerulonephritis. CT head showing starry sky appearance. You get this in case of neurocysticercosis. Ultrasound abdomen of the liver showing starry sky appearance. That will be viral hepatitis. Okay, that will be viral hepatitis. Okay, right. So that was some points related to acute. But what is very, very important in the entire hepatitis, acute and chronic, serology is very, very important. Right? Serology is very, very important. Now, let me just tell you or discuss about the serology. Okay. So, role of serological markers in hepatitis B virus. So, you see this question. Early diagnosis of acute hepatitis B infection is made by presence of envelope antigen, presence of IgM anti-HBC in the serum, presence of surface antigen in the serum, presence of IgG anti-HBC in the serum. So what is that? It will tell you that it's an acute infection. Now, when you are having options like this, like you need to act little cleverly. So there is very high chance that you may go with the surface antigen, right? You may go with surface antigen. This is also a correct answer. But the best answer here will be the presence of IgM anti-HBC. Actually, in acute hepatitis, you get this both. Surface antigen will be positive and IgM anti-HBC also will be positive. But why is that we don't go with surface antigen is that because the surface antigen is also positive in case of the chronic hepatitis. Surface antigen is also positive in carriers. Right? Surface antigen is also positive in carriers. Okay. So that is about the story of the surface antigen, in which all conditions it will be positive. Then what about the anti-HBs? The another important serological marker is the anti-HBs. If anti-HBs is positive, that indicates the development of immunity, right? That indicates the development of immunity. That means the individual is immune. The individual is like cured of the hepatitis B infection, or the individual has no active disease. right? The individual has no active disease. So that is what is your the presence of anti-HBs AG tells you. Now, what about the other serology in the options which has been given to you? The presence of IgG anti-HBC, that tells you that the patient is having chronic hepatitis. And what about the presence of the envelope antigen? See, the presence of envelope antigen, that is HBeAg, that tells you that the individual is having higher infectivity with hepatitis B virus. Right? The individual is having higher infectivity with hepatitis B virus. Okay. So the presence of envelope antigen. So infectivity, if you see this question, right? So hepatitis B infectivity is indicated by, right? Anti-HBs AG, surface antigen plus envelope antigen, anti-HBs plus anti-HBC, anti-HBe plus anti-HBs. So that is the presence of HBs and envelope antigen tells that the individual is having, the individual is like highly infective. That means the virus is like replicating. The virus is like replicating. That is what is the importance of the envelope antigen. The next question you see here, a 30-year man presented with nausea, fever and jaundice of 5 days duration. The biochemical test revealed the bilirubin of 6.7 milligrams per deciliter, SGOT, SGPT 1230 and 900 international units per ml. The serological test shows the presence of surface antigen, IgM anti-HBC and envelope antigen. So what is the most likely diagnosis in this question? So the options are chronic hepatitis B infection with high infectivity, chronic acute hepatitis B with high infectivity, chronic hepatitis B with low infectivity and acute hepatitis B with low infectivity. So you are having the presence of IgM anti-HBC. That means it is acute hepatitis. And next to that, the individual is having the envelope antigen. That tells the individual is having acute hepatitis with high infectivity, right? Acute hepatitis with high infectivity. And one more important serological markers that are being asked previously is about the replication. So, right, the presence of the replication. So, what are the markers of the HBV replication? The markers of the HBV replication, we have two important types of markers. Like we have a qualitative marker and we have the quantitative marker. So, you take the qualitative marker. The qualitative marker will be the envelope antigen. Right? The qualitative marker will be the envelope antigen. Whereas, you take the quantitative marker. The quantitative marker will be HBV DNA and DNA polymerase. Right? The quantitative marker will be HBV DNA and as well as DNA polymerase. Out of all these, which is the definitive marker of viral replication? The definitive marker of the viral replication is the DNA polymerase. So DNA polymerase is a definitive marker of the viral replication, and these three are the markers of the HBV replication: HBV DNA, DNA polymerase and envelope antigen. Envelope antigen, it is a qualitative marker. And once we are done with the, okay, and some more points, right? IgM anti-HBC, what is this? Acute hepatitis. HBs AG and IgM anti-HBs AG. HBs AG plus and IgM anti-HBC AG is positive. So what does that tells you? See, the presence of HBs AG and as well as the IgM anti-HBC antigen, this again tells you the same thing, that is acute viral hepatitis. Right? Acute viral hepatitis. And this IgM anti-HBC, either it tells you acute hepatitis or it tells you that the individual is in window period. Right? Or it will tell you that the individual is in window period. And along with surface antigen, if there is IgG, that tells it is chronic hepatitis. And if there is anti-HBs AG, that tells that the individual is like vaccinated, or the individual is like immune, or the individual is like cured of the disease. Okay, right. So this is about the serological markers, which is very important question in the hepatitis B. Now the next important thing is related to the treatment. Next important thing is related to treatment. But before that, there is one question which has been asked previously related to the gene. Related to the gene. Reverse transcriptase of hepatitis B virus is coded on the following gene: C gene, S gene, P gene, X gene. Remember, it is the P gene which is the largest gene. This P gene is the one which codes for DNA polymerase. Right? This codes for DNA polymerase. Okay. So the enzyme DNA polymerase, it has both DNA dependent DNA polymerase activity and RNA dependent reverse transcriptase activity. So that is about the story of the reverse transcriptase of the hepatitis B virus is coded on the following gene, that is the P gene. Now you see the questions related to the treatment. Which one of the following pairs, right? Which one of the following pair is not correct regarding the hepatitis B management? Supportive care, acute viral hepatitis B, antiviral drug, chronic viral hepatitis B, supportive care, chronic viral hepatitis B, antiviral drugs, acute viral hepatitis B. So remember, in case of acute viral hepatitis, there is no role of antiviral drugs, right? There is no role of antiviral drugs in case of acute viral hepatitis B, right? In acute viral hepatitis B, it is only just supportive care. We don't give antiviral drugs. But whereas in chronic hepatitis, we give both antiviral and as well as the supportive care both. Okay. Whereas in acute, it is only supportive treatment, symptomatic treatment. There is no role of the antiviral drugs, right? Next, then you take the treatment of chronic HBV infection. So which are all the drugs which are given in the treatment of the chronic HBV infection? So we have almost a list of around 6 to 7 drugs. Among the options which has been given to you, interferon is the answer, adifovir is the answer, lamivudine is also answer. This famciclovir, ganciclovir we don't give for HBV. So what are all the drugs we give for the hepatitis B infection? One is your interferon, the other one is lamivudine, third one is adifovir, next is entecavir, then telbivudine, then tenofovir. So these are the drugs which are given for chronic HBV infection, right? But out of all these, which are the first line drugs? Out of all these, the first line drugs will be PET. What does this PET stands for? Pegylated interferon, then entecavir, then tenofovir. So these are the drugs which are first line for the treatment of the viral hepatitis, right? Next, then when is that you need to start the antiviral drugs for chronic hepatitis is the next important question. So you see this clinical scenario. A young man presents with the surface antigen positive, then anti-HBC IgG positive, envelope antigen negative, normal levels of AST and ALT, asymptomatic. What is the next line of management in this patient? Wait and watch, lamivudine, immunoglobulin, liver transplantation. So here the answer is wait and watch. You need not start the antiviral drug, that is lamivudine. Why is that you need to just wait and watch in this individual, and what is the indication to start the antiviral drugs? See, the indication to start the antiviral drugs is that you need, see, if surface antigen is positive, it doesn't mean that you need to start the antiviral drugs, right? Or if IgG anti-HBC is positive, that means it is chronic hepatitis. That doesn't mean that you need to start the antiviral drugs. You need to check for the HBV DNA levels before starting the antiviral drugs, and you also need to check the HBeAg levels. HBeAg tells you what? That is the infectivity. It tells you about the infectivity. Okay. So if HBeAg is positive and if HBV DNA levels, this is the latest data what I am telling you. Latest data is that if the value of your HBV DNA levels, if it is more than or equal to 2 into 10 to the power of 4 international units DNA per ml, that is the point when, right, that is the point when you need to give, that is the point when you need to start the antiviral drugs. Okay, this is the latest data. But here if you see, like envelope antigen is negative, that means what? Envelope antigen is negative means low infectivity, and AST and ALT is normal, that means there is no hepatitis, right? There is no severe form of hepatitis. So that is the reason why in this patient you need not start the antiviral drugs, you just need to wait and watch, and then you need to monitor the HBV DNA levels, AST and ALT levels. Okay, right. So that was about your hepatitis B. Now the next important thing in the GAT is the hepatitis C, that is viral hepatitis C. So now if you take the hepatitis C virus, that is the most common virus which is associated with transfusion associated hepatitis. Okay, so this is being transmitted most commonly via transfusion. Okay, so the most common, and the other method is by the percutaneous route. So basically what I mean to tell is the parenteral routes, right? Parenteral routes. And remember, your hepatitis C is not spread through fecal-oral route. Is not spread through the fecal-oral route. And for this hepatitis C, there is no vaccine or prophylaxis which is being available. And this hepatitis C virus, if you see, it is the one which has the highest malignant potential. Malignant potential is highest for the hepatitis C virus, right? And also in hepatitis B. Now, if you take the antibodies in hepatitis C virus, the antibodies are anti-LKM antibodies. The antibodies are anti-LKM antibodies, right? So the LKM stands for what? The LKM antibody, they stands for antibodies against liver, kidney, microsome, right? Antibodies against liver, kidney and microsome. That is what is the anti-LKM antibodies, right? And these anti-LKM antibodies are detected in the sera of the patient, and these antibodies, they act against what? These antibodies are targeted against cytochrome P450 component, right? It is targeted against, right? It is targeted against cytochrome P450 component. That is very, very important, right? Which is the second messenger. Now, what type of LKM antibodies you have in case of hepatitis C? See, anti-LKM antibodies, you have anti-LKM 1, 2, 3. The type of anti-LKM antibodies that you will have in hepatitis C is the anti-LKM 1. What about the others? You take the anti-LKM 2. Anti-LKM 2 is seen in case of drug-induced hepatitis. Right? In drug-induced hepatitis, you get this anti-LKM 2. Whereas, you take anti-LKM 3. Anti-LKM 3, it is positive in case of chronic hepatitis D. Right? In chronic hepatitis D, you have this anti-LKM 3. Right? So, that is about the antibodies. Now, let me tell you, in these patients with hepatitis C, it is not just only, right, the hepatic manifestations. There are extrahepatic manifestations in hepatitis C. What are these extrahepatic manifestations in hepatitis C? It can cause abnormality within the blood. That means it can cause agranulocytosis. It can also cause aplastic anemia. It can also cause thrombocytopenia. Right? So, aplastic anemia, thrombocytopenia and agranulocytosis. Right? And other extrahepatic manifestations are, it can also cause diabetes mellitus. That is type 1 diabetes mellitus. And there can be also neurological manifestations, that is development of the Guillain-Barré syndrome, right? Development of Guillain-Barré syndrome, okay? And other malignancies like non-Hodgkin's lymphoma. These are all the one which can be caused by the hepatitis C virus. And even cryoglobulinemia. For the development of cryoglobulinic vasculitis, what is required is the hepatitis C is being required. So apart from these antibodies, what is the further workup which is required? Right? Definitely yes, anti-LKM 1 antibodies are there, it is HCV infection, done. The next thing is you have to check for the HCV RNA levels. Once you find that there is detectable levels of the HCV RNA, that tells the patient is having chronic hepatitis C. For suppose, if the patient is not having, that means there is no detectable HCV RNA levels. If there is no detectable levels of the HCV RNA, then you need to consider it is not chronic hepatitis. Right? It is not chronic hepatitis. Okay. Then what is the indication for treatment of your viral hepatitis? The indication for treatment is that after checking the anti-LKM antibodies, after finding that there is significant levels of your HCV RNA levels, then you have to check the ALT levels, right? If the ALT levels are elevated more than 2 to 3 times, that is the point when you need to start the antiviral drugs. That is the point when you need to start the antiviral drugs. For suppose there is like detectable HCV RNA, we are considering it as chronic, but there is like normal ALT levels. When there is normal ALT levels, whether to start treatment or not, that will be decided by doing the liver biopsy, right? That will be decided by doing liver biopsy, right? So perform the liver biopsy to obtain the histopathological diagnosis and staging of the chronic hepatitis. And in the liver biopsy, if it shows that there is chronic hepatitis, then you start the antiviral drugs. Now, what are the antiviral drugs that you give in case of the chronic hepatitis? So, this hepatitis, you have like genotype 1, you have genotype 2. So, for genotype 1, the drug of choice will be ledipsavir. Right? For genotype 1, the drug of choice will be ledipsavir. And for genotype 2, the drug of choice will be sofosbuvir, and the other drug will be ribavirin. Right? The other drug will be ribavirin. Okay. So these are the treatment options for genotype 2. And you should know the prognosis also. So which particular type of hepatitis C virus has sustained, that means good response? The one which has reduced responsiveness. See, genotype 1, it has reduced responsiveness. But whereas genotype 2, it has sustained responsiveness. Right? Sustained responsiveness. So if the individual is being infected with genotype 1, the prognosis will be bad. Right? The prognosis will be bad. And the other points to tell that the prognosis will be bad in hepatitis C virus is that one is your genotype 1. And second is, if there is high levels of HCV RNA, worst prognosis. Advanced fibrosis on the histology, worst prognosis. Right? And there is long duration of the disease of your hepatitis C, then also the prognosis is bad. Age of the individual more than 40 years, then also the prognosis is bad. The patient is like immunosuppressed, then also the prognosis is bad in case of hepatitis C. The individual is like obese, the prognosis is bad. Okay. So, and if the adherence is not good, then also the prognosis is bad. And males, they have bad prognosis than compared to that of females. Right? Males, they have reduced responsiveness to your antiviral drugs than compared to that of females. Females, they have sustained responsiveness for your chronic hepatitis C treatment. Okay. So this is about the hepatitis C. So with this, we are done with the GAT rapid revision. Right? So in the GAT, like what all topics we have discussed is mainly the cirrhosis of liver and as well as the complications of cirrhosis of liver. And the next important thing in the GAT is the hepatology, right? That is your viral hepatitis. See, majority of your GAT, like you will be read in the surgery. So which I am not going into your peptic ulcer disease or malignancy, stomach carcinoma and all. What is very important in medicine, right? I have tried to discuss that. Okay. So with this, we'll try to wind up this particular session now, right? So two more topics, that is infectious diseases and hematology is there. I will try to make out one more day, right? It is not tomorrow. I'll try to make out one more day to discuss infectious diseases and as well as hematology. Actually, infectious disease is a topic of your microbiology, but what we discuss in medicine is treatment only. And even hematology, it's a topic of pathology, right? What we discuss in here is only the treatment in hematology. So these two topics, I'll try to make out one more day before your exams, and I'll try to do a quick revision of the infectious diseases and as well as hematology subsequently. Okay. So with this, I'll wind up the today's session. So thank you very much. See you in the subsequent sessions. And any doubts, right, you can text me on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gupta, right? So I may respond quickly or a little late, but definitely I'll respond. So you can just, so whatever the doubts you are posting in the chat, you can just text me on my Telegram channel. Definitely I'll respond to you. Okay. So thank you very much. See you again in one more session for the discussion of infectious diseases and hematology, and then that will be done with your entire NEET PG rapid revision of the general medicine. Thank you very much. See you in the upcoming session.